We are live now.
Oh.
Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, episode 29 of Amogs Emergency Obstetrics Committee with Punjab Societies. It's my privilege to introduce the MOC of today's webinar, Dr. Madan Kambal sir. Sir is a consultant obstetrician and gynecologist and also past secretary and president of Akluj OBGY Society. Currently, sir is the chairperson of Amogs Aesthetic and Sexual Medicine Committee.
It's okay. It's okay, Said.
And I hand over the session to you.
Thank you, Saiti. Good evening, all, and warm welcome to this 29th episode of series of webinar organized by Amogs Emergency Obstetrics Committee of Amogs, along with the Punjab Societies. I welcome all the office bearers and all the delegates of from Punjab Societies. With the blessings of Amogs office bearers, President Amogs Dr. Kiran Koti sir, Secretary Dr. Bipin Pandit sir, Dr. Rajendra Singh Pardeshi sir, immediate past president, and all the Amogs office bearers, I take this privilege to welcome you all. May I have CVF convener? Yes. Yeah. Today's convener is Dr. Vidhu Modgil, who is the director and senior consultant, Suman Hospital, Ludhiana, infertility specialist. She is a life member of Foxy, ISAR, SAPO, Indian Fertility Society, also past president of Ludhiana Society, past secretary of Ludhiana Society, life member of NARCH. I welcome Dr. Vidhu. And also I welcome the conveners, today's coordinators, Dr. Kavita Bhatti ma'am, who is the vice president, Ludhiana OBGY Society, and professor and head of the department at CMC Ludhiana. Second coordinator, I welcome Dr. Sangeeta Pava, who is the president of Amritsar Menopause Society. And she is on editorial board of Indian Journal of Obstetrics and Gynec Research. And she is the head of the department of OBGY at SGRD Amritsar. I welcome both the coordinators. And I hand over to Dr. Vidhu ma'am for further proceedings to welcome Dr. Sneha ma'am, who is the brainchild behind this series. Thank you all. Over to you, Dr. Vidhu ma'am.
Yeah, Vidhu can say a few words about this program. Yes.
Yeah. So good evening to one and all, to all my seniors and to my colleagues who are part of this. And thank you, Dr. Sneha ma'am, for this opportunity for being a part of this great webinar series, which actually we can learn from each other, and we can also learn the new ways and means of handling various issues of aesthetics emergencies. So it has been a ongoing program Dr. Sneha has been doing with different kind of webinars which have been promoted to as webinar series to learn from various topics of obstetrics. Today's topics are very interesting, like thromboprophylaxis and cholestasis, which are very, very important in our day-to-day practice, and we commonly see them. And we have two great speakers, which will be good view of this literature. I would just like to introduce the brainchild behind this program, Dr. Sneha. Everybody knows her. She has actually traveled from throughout India, and she has been a great person who has motivated many people to be a part of many academic programs. Dr. Sneha, she's a candidate for vice president from the West Zone. We can see from her CV, she has International MS Signature Award, she has SN Malhotra Individual Award, and many awards to her credit. She has written 30 chapters and articles as national publications. She has been a Foxy Breast Committee Chairperson, GMC ICOG 2021-22, National Roles in Trainee, National Expert UNICEF, Peer Reviewer in Jogi, Amogs Chairperson, and many more things to her.
Thank you. Thank you, my dear. Thank you so much.
And I'd like to welcome her and she'll take over from this.
Thank you so much. I would just, in short, welcome everybody and just request Sahiti to go ahead with the invocation video, let us have the blessings of God. Ganesha. So with the blessings of God and we would like to go ahead with this program to seek the blessings of our seniors and of course our mentors and guides. So a very good evening to one and all. My respect and regards to all the seniors here. With a special mention of respected Dr. Iqbal Singh Ahuja, the chief guest for today's program, Madam Lakhbir Daliwal and Madam Madhu Nagpal. The entire team of course, Madam Sushma Chawla as guest of honor today, and entire team of Amogs, Dr. Kiran Kurtakoti, President of Amogs, Secretary Dr. Bipin Pandit, and immediate past President Dr. Rajendra Singh Pardesi, our Treasurer Dr. Madhuri Mehndar, and of course, a dear friend Dr. Parag Biniwale, who is the National Coordinator of Amogs, and of course, the chairperson-elect of ICOG. I welcome all the speakers for today's session, Dr. Uday Thanawala, who will be speaking on thromboprophylaxis, and Dr. Geeta Balsarkar, who will be speaking on the cholestasis in pregnancy, and I'll be moderating the panel discussion on hyperglycemia in pregnancy, which is such a commonly encountered situation nowadays. I welcome all the respected chairpersons with special mention to Parmit Kaur, Madam Madhu Nagpal, and of course the Rama Sofat, Madam Preeti Kamal, Dr. Manjit Singh Sidhu, Dr. Kavita Mandal Bhatti, Dr. Sangita Pahava, and my dear panelists, Dr. Shumila Basi, Dr. Satinder Palkar, Dr. Nitika Chabra, Dr. Preeti Dev, Dr. Sandesh, Dr. Pooja, Dr. Shail Kaur, my dear convener, Dr. Vidhu Modgil, and my coordinators, Dr. Kavita and Sangeeta, my dear friends, and of course from Amogs, Dr. Monica and Dr. Madan. They have taken lots of efforts to formulate this program and bring everybody together. So I would like to thank God as well as thank everybody for this, wonderful program coming up. So I would request Dr. Iqbal Singh Ahuja to bless us and guide us on this subject. And sir, of course, I have met you physically as well as, virtually so often. He's the senior most obstetrician gynecologist, the director of Iqbal Nursing Home and Hospital, Ludhiana. 55 years of service to medical field. I mean, just beyond imagination, I would say, and sir is still serving the humanity. So many awards and accolades to her. It's credit right from up to the lifetime achievement of all the organizations, I would say. And we are blessed to have you, sir, and eagerly waiting for the words of blessings. Over to you.
And thank you, Dr. Sneha. It's my pleasure to see you all. And I think that this is the best opportunity when you can pay regards to your colleagues and who are very intelligent. And I have no words to say for the intelligence and efficiency. I am just now, I feel very small when I see all these people in front of me. First, I start with you, Dr. Sneha. Thank you. You are spreading knowledge. You are Dr. Sneha. Sneha is love. Okay. So the post you are contesting it, I think you definitely love begets love. Okay, Sneha is love. So I don't think there's any chance. Everybody will vote for you, and I don't think you should have tensions. My regards to Dr. Kiran, Dr. Bipin, Dr. Madhuri, and Dr. Rajendra for the rights of the Bombay Society. And, thank you very much for choosing me as a chief guest, which is very difficult. I think I can't imagine why my name crops up. But thank you very much. And when I see Dr. Paragwala, I met, very nice. I have no words to mention. First of all, I'll say a few words. Thank you about my local colleagues, Dr. Vidhu, Dr. Kavita. Because if I don't say anything about them, then it's difficult to survive in the same city where your colleagues are there. So, regards to Vidhu and regards to Dr. Kavita and my senior Dr. Sufat. We are working in the same city. Dr. Lakhvir, she was in CMC from where I studied. And she's a very beautiful girl, Dr. Sushma Chawla, was very senior and still young. I think everybody knows Dr. Madhu, special regards. She is very good colleague of my wife. And I think my regards to everybody. I think we are involved in Punjab, every city, Faridkot people, Naba people, Amritsar people. SERD is Dr. Sangeeta Pawar is very special to me. I was on the board of the directors in the same university when it was made university. Dr. Shimela Basi is from local. And, I can see Dr. Sandesh, Dr. Pooja, Dr. Chek. Difficult to mention all the names, but thank you very much for this. Now, I think what we need is in practice is goodwill, love, and intelligence. These things would be for everybody, in especially in our profession. Somehow jealousy crept in, and knowingly well that this will not harm the other persons, we still speak of others. No, and especially when we get a patient from one doctor to another one, I think we should restrict. I have made it point. I always respect the slips, prescription slip of everybody, and this was a disease which was few years before. Now, the younger generation, I think this disease is decreasing, and I wish well that they should think of their colleagues in such a nice way that so when you meet, you can without being guilty. This is what is happening. We speak ill, we speak against our colleagues, and when we meet, we can't meet them so happily. One thing we should avoid this thing. Everybody is perfect. Nobody is perfect. If you are a doctor, you are a perfect doctor. But circumstances, facilities are different with everybody. Now things have changed. When I was working in CMC, we had patients who were lying on the gate for 3 hours without dying because blood will not come at least for 3 hours, 4 hours, and they will not die. Now, patient comes and you don't get time to resuscitate even, and they then still you are blamed for that. Things are changing. I don't know whether distance has increased or time has increased, but now death comes so soon because heart attack, severe diabetes, other problems are so much which were probably not there at that time. Now the stress and everything. What I feel is love, Sneha, spread your love everywhere. Let every doctor love each other, spread knowledge. And I think that these webinars are the best thing to do. Even in classroom, only few students can learn. In webinar, I think whole of India is learning. Thank you very much for doing such a great work. I wish you all the best.
Sir, thank you so much, sir. And of course, it's always been my, my humble attempts to spread knowledge and, of course, love as well. So thank you so much for all your blessings and guidance, sir. Now I welcome my dear Madam Sushma Chawla, whom all of you know, yes, brain and beauty, such a gorgeous lady with a golden heart, I would say. Madam is the professor, honorary professor and dean, of course, the Dawn ICMCH, and of course, she is the managing director of the Chawla Nursing Home. Of course, so many awards and accolades I'm not going to read, Madam. We are just eager to see you and listen to you. Over to you, Madam Sushma Chawla.
Thank you very much, Dr. Sneha. And I think Dr. Vidhu and Dr. Kavita for inviting me for this webinar. I think this is a very beautiful platform to meet each other and exchange knowledge. And I think today's topics are really great. And DBT and diabetes, which we come across every other day. And of course, updating is very important. And as Dr. Iqbal said, we should be meeting, greeting happily and of course, referring patients to each other wherever the areas are in different states, because we have patients come from very far off and from different places also. So I think knowledge is tremendous and we have to update ourselves. And I wish all the speakers today for a great evening and the panelists also. I think I'm also going to learn a lot. Thank you very much for inviting me as a guest of honor. Thanks you for this honor. Thanks. And I wish you a very bright future for yourself. Your endeavors should be.
Thank you so much, madam. Your blessings are always there with me. So with this, I now welcome Madam Lakhbir Taliwal, who is the guest of honor for today's program. Madam is the former professor and head of department PGIMAR. And of course, just now Parag also shared about the memory. We are eager to listen to you, madam. Over to you for your precious words.
Good evening, all colleagues, seniors, students. It's a good platform. It brings all of us together often. And I'm very happy to be a part of today's webinar to revise the common obstetrical problems which we face every day. Cholestasis is becoming more common now, commoner than before. And thromboprophylaxis is not often discussed in our CMEs, but it can prevent a real obstetric emergency. So thromboprophylaxis is actually very important. And thank you, Dr. Sneha and the whole team of Emergency Obstetric Committee to club the smaller societies and bring them at the same platform, and we all can upgrade our academics. So thank you very much for this academic program. Everybody will definitely learn from this, and best wishes for your future endeavor.
Thank you so much, madam. Thank you so much. Now I welcome Dr. Kiran Kurtakoti, President of Amogs, for his precious words, of course, about this program.
Thank you, Sneha. First of all, a very happy Guru Purnima to all of you. And thank you that all of you are on the Amogs platform. My regards to Dr. Iqbal, who is today's chief guest. My regards to Dr. Lakhbirji Dhariwal and Dr. Sushma Chawla. And Sneha, thank you for bringing me today, because if my memory corrects, if my memory suits me correct, Dr. Lakhbir Dhariwal was my examiner when I took my DNB exam. So really, it's a good thing. It's a good thing. And thank you, madam, for passing me on my first.
I hope I passed you with good grades.
Yeah, you passed me in my first attempt. In fact, of the batch of 40 people, I think I was amongst the only 6 people who passed that batch. So thank you for passing me.
Actually, DNB passing is more difficult than MD.
Yes.
Definitely.
Yes, madam.
Entering is easy. Getting out of this is more difficult.
I know. But thank you for doing the honors for me about, say, 30 years back. Thank you so much for that. And Sneha, really a lovely piece of, all fantastic orators that you have got. In fact, we were learning about what is exactly Dawn DGO. So thank you for getting Dr. Sushma Chawla also, who is the Dean of the Dawn ICMCH. And for your information, Sushma Madam, there are a lot of people who have passed out from the Dawn ICMCH who are giving excellent services to all the remote areas in Maharashtra. And it will be my humble attempt to incorporate them also in the fellowship programs. Okay, because few things they are not recognized as fellows somewhere else, but definitely we are going to incorporate them as our fellows. And really, I appreciate Sneha's gesture of bringing Dr. Sushma here on this platform. So thank you so much. Thank you. And my regards to Dr. Pardeshi. Hello to Uday, and a very warm welcome and greeting to Dr. Parag, who is like my brother in Pune society as well as in Foxy, a mentor of many of the Pune people. And Sneha, what I should say about you, you are having marathon webinars after webinars. I think you have taught so many people and you have brought so many teachers on this platform that really I don't think you should have any issues, but my best wishes, and Amogs is always with you. My regards to Madhuji and Nidhika ji also, and to today's conveners. Thank you so much. And I would request you to get on with the program. Thank you. Thank you.
Thank you so much, Kiran. Thank you for all your precious words and, of course, precious wishes as well. I would just request a few words from immediate past president of Amogs, Dr. Rajendra Singh Pardesi, followed by our Dr. Parag Beniwal. Yes.
It's okay.
Yes, sir.
Respected Chief Guest, Dr. Iqbal Singh Ahuja, Guest of Honors, Dr. Sushma Chawla, Dr. Lakhbir Dhaliwal, ma'am, our President, Dr. Kiran Kurtakoti, Dr. Parag Benewale, then Dr. Uday Thanawala, Dr. Gita Balsarkar, and our active chairpersons, Dr. Madan Kamble and Dr. Sneha Boyar. So feeling proud and honored to be a part of this program with legends like Dr. Iqbal Singh, Dr. Lakhbir Dhaliwal, Dr. Sushma Chawla, Dr. Madhu Nagpal, and all others. And it's a due to thank you, Dr. Sneha. For you only, I can meet these people, these legends in our obstetric and gynecology. So I wish to express my sincere thanks to Nava, Amritsar, Ludhiana, Bhatinda, Jalandhar, and Firozpur societies for their active participation in this program. Congratulate again to Dr. Sneha Boya, Dr. Monica, Dr. Sangeeta, Dr. Kavita for organizing this webinar on important topics. I wish every success to Dr. Sneha Boya for her future endeavor in FOXI. She is contesting for the post of Vice President of FOXI. I think she deserves this post. Again, I wish every success. Wishing every success to this webinar. I don't want to be in between you and scientific content. Thank you. Thank you so much for inviting me. Thank you.
Thank you, sir. Thank you so much. And Parag, we are eager to listen to your precious words as well.
Yeah, thank you, Sneha. Thank you especially for getting me back to Punjab. I have been to all these societies and I've seen the legends like Dr. Ahuja, Dr. Madhu Nagpal, who was the HOD and president of Amritsar when I visited it. Dr. Lakhbir, I had visited her at Chandigarh, and our all-time favorite in Indian Menopause Society, Dr. Sushma Chawla. Of course, it's a great exchange of knowledge that we are looking forward to. And on behalf of Amogs, I must appreciate your efforts to get in touch with the other states where there is good exchange of knowledge. We learn from these senior people, and of course, we discuss with them the knowledge that we have. So my best wishes for the program. Sneha, best wishes to you. You really deserve this recognition. Thank you very much.
Thank you so much, Parag. So let me just share with you that this is the third year consecutively we have been, organizing programs, not only virtually, but also on-site programs. And this month, I'm almost the whole month, every day I'm traveling to some other place. I have connected with the entire India. I would say this is the second round, and more than 100 programs we have already done. So that's a very reason all of you are so close to us, and I'm sure all of you have experienced the depth of knowledge also. Thank you so much for all your appreciations. And with this, I thank all of you. And once again, I hand over the forum to our coordinators, Dr. Monica, and of course, Dr. Kavita Bhatti. I can see Kavita. Hello, if you can put on your video, please. So I would hand over the forum to the coordinators, Dr. Kavita Bhatti, and of course, Dr. Sangeeta Pahwa, our dear friend from Amritsar. Over to both of you. I just welcome Dr. Uday Thanawala, who has just joined. Sir is the speaker for today's program. And we have already welcomed you officially. Once again, I welcome you, sir.
Thank you, everyone, for joining us for the inauguration today. This is the 29th episode of the Amogs Emergency Obstetric Committee with Punjab Societies. And I would like to thank our chief guest, Iqbal Ahuja, sir, our guest of honor, Sushma Madam, and our Amogs office bearer, Kiran, sir, Bipin, sir, Pardeshi, sir, and Parag, sir, for joining us today. We will start with the first academic session, that is thromboprophylaxis in pregnancy. I would take privilege in introducing our chairpersons for the same. Dr. Parneet Kaur, Madam, has a teaching experience of around 23 years. She has been an examiner for undergraduate and postgraduate for the last 14 years. She has more than 70 publications to her credit and has contributed in 3 books. She is also a reviewer of 3 reputed specialty journals and currently the president of Naba Obstetrics Society. Her special interests include high-risk pregnancy, emergency obstetrics, and contraception. She's also a master trainer for PPIUCD. We welcome you, ma'am. Our next chairperson is Dr. Madhu Nagpal, madam. She is the ex-professor and head of the Department of GMC, Amritsar. She has been awarded distinction in physiology and medicine and the best postgraduate of GNDU. She has more than 42 years of academic teaching experience in the field of OBGYN. Her special interests include medical teaching, practical obstetrics, and contraception. She is also regional faculty for certificate courses on GDM contraception with the PHFI. More than 105 papers of publication. Books. We welcome you, ma'am. Our next chairperson for today, Dr. Vidhu Mudgal, madam. She is the director and senior. Yes, ma'am.
Thank you. I have been already introduced.
She has been
So
introduced.
let's
Yes,
start.
ma'am. Sure, ma'am.
Thank
I request the chairpersons to please take over the session. And to introduce our speaker for today,
I
Dr.
would-
Uday Thanewala, sir. Yes, ma'am.
Yeah. So I welcome Dr. Uday Thanewala. He is a consultant obstetrics and gynecologist at Navi Mumbai. Chairman Indian College of Obstetrics and Gynae 21-22, Vice President Federation of Obstetric Gynae 2015, Treasurer PCOS Society of India, Chairperson Medical Disorders, Pregnancy Committee of OXY, Founder Secretary and Past President of Navi Mumbai Society, Joint Secretary OXY, and Gold
Thank
Medal
you.
in FRCF. So, sir, we
Thank you,
welcome
Dr.
you for
Vidhu.
your talk.
Thank you, Dr. Vidhu. So the first time when Sneha asked me that will I come and speak on thromboprophylaxis, yes, it's a topic which I love speaking on, and there's so much of confusion in this topic of
Absolutely.
when to use heparin in which patient. I said, yeah, I don't mind, but then when she told me the time, I said, no, I'm in between my OPD. My OPD starts at 5, so I don't think I can do it. But when Sneha asked something, we can't refuse because she has done so much of work for me when I was the ICOG chairman. She has conducted workshops. She's taken so many events and responsibilities on her shoulders, and she's such a great worker that it's impossible to refuse Sneha for anything at all. So thank you, Sneha, for having me here and remembering me to take this particular lecture. Dr. Lakbir, Dr. Madhu Nagpal, well, we've been associated since so many years, Dr. Sushma Chawla, and also my greetings to everybody, and especially Kiran, because Kiran and Parag, of course, they're very, very close and close friends. So thank you for having me here. So without wasting much time, I will start the presentation, which is thromboprophylaxis. What is the rational use of thromboprophylaxis in sorry. So what is the rational use of thromboprophylaxis in pregnancy? Let's look at some clinical scenarios because it's important to relate everything what we do in practice or theory into clinical practice. So let's look at these couple of patients and we'll come to it. After eight consecutive miscarriages, patient A has recurrent miscarriage screening. All blood tests return normal. You have done your APLS screening, you have done your all other screenings, which we will talk about. And she inquires what medication to use in subsequent pregnancy. So will you give her heparin? That is the question. Patient B presents with a positive pregnancy test. She has 2 DBTs in the past 7 years. Patient C is pregnant for the first time. Her sister is positive for APS and has aspirin and heparin treatment after 4 pregnancy losses. So will you give her heparin? Patient D is diagnosed with APS and has 3 miscarriages. She is now 5.3 weeks. 6 weeks duration postpartum for a patient E who is heterozygous for factor V lead. So just think about in which clinical situations of these will you use heparin. So let's see what the answers are. After 8 consecutive miscarriages, because her screening has all come negative, no, we will not put her on heparin or aspirin. Heparin and aspirin because she's got 8 consecutive miscarriages. Patient B presents with a positive pregnancy test. She's got 2 DVTs in the past 7 years. Obviously, this patient requires heparin because pregnancy itself increases the coagulation, the profile of the coagulation. So you need to give her heparin. Now, patient C is pregnant for the first time. Her sister has got history of APS, but she's got nothing to do with it. It's not a familial condition. So no, she also doesn't require heparin. Patient D is diagnosed with APS and has 3 miscarriages. She is now 5.3 weeks. Yes, this patient does require heparin. And 8 weeks duration in the postpartum for patient E, who is heterozygous for factor V laden. Yes, she also requires heparin to prevent a DVT in her postpartum period. So that is how one has to fit in which cases one requires heparin. So in recurrent pregnancy loss, if you have a patient with 3 previous abortions, all 3 first trimester abortions at 6 to 11 weeks, ask what are the chances of having a normal child. Now, this is how the patient presents to you. She wants to know what are her chances of having a normal child. So what are you going to tell her? So you have to tell her that after 1 spontaneous abortion, the chances of having a second spontaneous abortion remain at 15%. That is, even in the first pregnancy, you've got a 15% chance of aborting. After 2 consecutive abortions, the chances rise by 25 to 30%. And after 3 consecutive abortions, she is at the risk of 33 to 45% of having the 4th abortion. But it is not all bleak. It is never 100%. Though the patient may feel that this is terrible, we have to bring it to her notice that have faith, and if you are lucky, you may just have a normal pregnancy and deliver normally. So a patient who has a live birth in between any of these abortions, the risk comes down to 30%. Even if you have a live birth followed by 2 or 3 abortions, the risk is much, much less. So this is what we have to keep in mind when we are dealing with a patient who comes with multiple abortions in the past. And after investigation, the contributing factor can be identified in 40 to 50% of the time. When treated, the prognosis for successful pregnancy outcome is typically about 80%. Even in couples where no underlying problem is found, the chances of a successful pregnancy can typically be in range of 50 to 70%. So now, this is what you have to keep in mind when counseling the patient. These patients who come with repeated abortions, they are totally shattered and they have very little hope. So we have to first give them the hope, what they call tender loving care, and tell them that things are not too bad. We'll investigate and we'll see what it is. So etiological factors which you look into is anatomical factors, easily correctable, good result. You find a septum, you find a uterus which is a subseptate uterus or something, or adhesions, you can deal with that. But today we are going to talk, we have got endocrine factors and we all start progesterone anyway. So we are not going to talk about progesterone. Very few of them are genetic. Very few of them are genetic. And normally when you send husband and wife's karyotype, obviously it comes out normal male and normal female. So there are very few genetic conditions which can cause to multiple abortions. Very few are related to infection. But what we are going to talk about today is thrombophilias. And this is what takes up a major chunk of repeated pregnancy losses. So the question about empirical anticoagulant treatment based only on history. A lot of studies have said that no, there is no benefit of starting low dose aspirin or low molecular weight heparin in cases of unexplained RPL. So that is why we say that even with multiple abortions, if the tests come out positive, maybe we should refrain from starting heparin and aspirin. Let's look at one clinical situation. Gravida 5 comes at 6 weeks of pregnancy. 1 missed abortion at 9 weeks. 2nd chemical pregnancy. 3rd ectopic pregnancy. Left salpingectomy was done. Then an HSG was done for secondary infertility. Cavity was normal. So the uterine cavity was normal and the right tube was patent. She again conceived and landed with a missed abortion at 10 weeks, and the karyotype of the products of conception was normal. So technically, by definition, if you see repeated pregnancy losses, 3 or more consecutive pregnancy losses below 20 weeks of gestation, the Royal College says 3 spontaneous abortions, the American Society of Reproductive Medicine says 2, and you could have primary or secondary if one pregnancy progresses beyond 24 weeks. But ectopic and biochemical pregnancies are not included in the definition. So when we talk of thrombophilia, so which patient to investigate for thrombophilias? When you talk of thrombophilias, you have the acquired thrombophilias, that the antiphospholipid antibody syndrome, or the inherited ones like the activated protein C resistance factor V laden mutation, prothrombin gene mutation, protein S deficiency, protein C deficiency, antithrombin 3 deficiency, hyperhomocystinemia, and homozygote methyl tetraphthalate reductase deficiency. So all these thrombophilias are known to us. And how do you classify that this patient has got a thrombotic disorder? You should have either a vascular thrombosis and one of the criteria of pregnancy morbidity. So if the patient has a DVT, automatically she goes in for heparin. So it is a thing. Or if she doesn't have a vascular thrombosis, she's got no history of DVT, but in the pregnancy, she's got 3 or more unexplained consecutive miscarriages with anatomical, genetic, or hormonal causes excluded, 1 or more unexplained death of a morphologically normal fetus at or after 10 weeks of gestation, and 1 or more premature births of a morphologically normal neonate at or before 34 weeks of gestation associated with severe preeclampsia or severe placental insufficiency, yes, you're going to think of APLA syndrome, you're going to think of any of these things which we have just elaborated of thrombophilias. And in the laboratory criteria, you need to have the anticardiolipin, IgG or IgM, any positive, lupus anticoagulant positive, which is generally demonstrated by an activated partial thromboplastin time, a dilute prothrombin time, or a kaolin clotting time, or a dilute Russell Viper venom time. So basically, what do we also do? Anti-beta 2 glycoprotein. Initially it was thought that autoantibodies against phospholipid in the cell membranes, but now it is known that they actually recognize and bind to certain blood proteins, which bind to the phospholipid and not phospholipids themselves. So basically what we do, the 2 major proteins which are targeted, beta 2 glycoprotein is done. So what you need to have is 1 clinical criteria, either of vascular thrombosis or fetal morbidity, what we have elaborated, and 1 immunological criteria, either lupus anticoagulant positive or any of this anticardiolipin antibody positive or a beta 2 glycoprotein positive. So basically, screening guidelines according to ASHRAE is recommended for antiphospholipid after 2 pregnancy losses, and beta 2 glycoprotein can be also considered to be done after 2 pregnancy losses. So we had this patient where we did an IgGs and IgM, ACL was negative, but the dilute Russell Viper venom test came positive, and beta 2 glycoprotein was normal. So is treatment required for APLA? Do we treat these patients? So please remember, when you have an APLA syndrome present in a patient with recurrent miscarriage, the live birth weight in pregnancies with no pharmacological intervention has been reported to be as low as 10%. So 100% these patients, all of them require treatment. And this is the basic pathology why how phospholipid antibodies bind to trophoblast and exaggerate the complement activity and stimulate inflammatory cells causing injury. So in obstetric, APS treatment does help, and very good and fetal maternal outcomes are there when APL is treated. And the investigators define pure APS as pregnancy morbidity in women with no previous history of thrombosis. So if she doesn't have a DVT or something, but she has one of those pregnancy complications, plus she has got any of these 1 test positive, then we start anticoagulant therapy. So start aspirin and prophylactic dose of low molecular weight heparin when the pregnancy test is confirmed. As soon as your pregnancy test comes positive, you can put them on aspirin and heparin. There was some confusion about waiting till the heartbeat's present and all, but no, the recent recommendations is as soon as pregnancy test is positive, put them on aspirin and heparin. The rational use of heparin is that this drug, apart from its anticoagulant action, seems to promote successful implantation in early pregnancy. The explanation for this may be that the heparin binds APL and thus prevents APL, reducing the physiological coverage of trophoblastic cells with potent anticoagulant protein like NX6-5, but this remains to be established. But heparin and aspirin needs to be started as soon as your pregnancy test comes positive. What is the dose and what are the advantages of a low molecular weight heparin over unfractionated heparin? When do you start? When do you stop? So basically, the results are very good with low molecular weight heparin and aspirin. And even with unfractionated heparin, if the patient is not affording low molecular weight heparin, unfractionated heparin gives equal results. So basically, both are effective. But low molecular weight heparin during pregnancy offers a number of advantages like equivalent efficacy, once daily dosing, lower risk of heparin-induced thrombocytopenia and osteoporosis, and less intensive monitoring. But one can offer unfractionated heparin, but I think these days we hardly ever even prescribe that unless the patient is totally not affording. So basically, what is the dose? 40 milligrams a day subcutaneous of enoxaparin is normally used. But if you have to prescribe unfractionated heparin to some patient, then 5,000 units twice daily in the first trimester, 7,500 units in the second trimester, and 10,000 units twice in the third trimester. That is the dose for unfractionated heparin. Now, when do you give full anticoagulation and when do you give only what is full coagulation and what is regular coagulation? We use the regular one. For a patient who has got a deep vein thrombosis or a history of a deep vein thrombosis, we have to give full coagulation, and the dose is different. Instead of 40 milligrams, it is 1 milligram per kilogram for enoxaparin. And of course, the dose of subcutaneous doses are 12 to 8 hourly interval of unfractionated heparin. And this, it is better we do it in conjunction with a hematologist if we are treating a patient of deep vein thrombosis. What we normally use is the prophylactic dose of in the obstetric APS. So please remember, there's a difference in the dosages, and what do you monitor it? You have to maintain a mid-interval anti-factor 10A activity to approximately 0.05 to 0.2 units per milliliter. But basically, on low molecular weight heparin, if we are using, we really don't have to monitor too much. And generally, we just give the patients that. And once in a while, if monitoring is required, we have to do, it's more difficult, and you have to do a anti-factor 10A activity if you want to monitor the low molecular weight heparin. Side effects, be careful about boneless, and you get thrombocytopenia, immediate type, which is reversible and does not require discontinuation of therapy. Late onset immune type is severe and occurs 5 to 14 days. So, patients who are on heparin, after about 2 weeks, again, definitely do the CBC to see if if everything is normal and there is no thrombocytopenia. What is the dose of heparin? If you have something with a vascular disease, you definitely give prophylactic heparin if treatment for VET event is over. And if it is APLA, you give full anticoagulation. If you've got thrombophilia plus VET plus adverse pregnancy outcome, you give full anticoagulation. So anything with a vascular disorder, we give full anticoagulation. If it's only obstetric, we can give only the prophylactic dose, that is 40 international units per day. So when do we stop heparin and aspirin? Effectively stopping low molecular weight heparin 24 hours before planned induction of labor. Electively stopping prophylactic dose of low molecular weight heparin or unfractionated heparin at about 38 weeks of gestation to await spontaneous labor can be done, especially in obstetric APLs. Or you can switch from therapeutic unfractionated heparin at about 36, switch to therapeutic unfractionated heparin at 36 weeks. So that, whenever she goes into labor, you can just discontinue the heparin, and the low molecular weight heparin, we can stop at 36 weeks and switch over to unfractionated heparin. But in general, in practice, when we continue heparin, even if we stop 24 hours before delivery, the low molecular weight heparin, it is good enough. It really doesn't matter what you are doing. We'll come to some clinical situations where, suppose it is you have given the dose, what to do and how long to wait. We'll just elaborate on that. Let's talk before that. This is about the antiphospholipid antibody syndrome. Let's talk about inherent thrombophilias, how important they are, and does heparin help? Now, there's a strong association between second trimester miscarriage and inherited thrombophilias like factor V latent, factor 2 prothrom gene mutation, and protein S deficiency. So, women with second trimester miscarriage should be screened for inherent thrombophilias, including factor V latent, factor 2 prothrombin gene mutation, and protein S and protein C. So, what we do today for inherent thrombophilias, if we suspect something, patient has had previous mid-trimester abortions, then we do a factor V latent, protein C functional activity, and protein S free and total and functional activity. Now, it is a little confusing because there's no clear-cut evidence that the inherent thrombophilias will, create a problem. So, low risk inherent thrombophilias, less than 1% risk of VET in a pregnant patient without a personal history of VET. So, if she doesn't have a history of VT, then heterozygous factor V latent, it's very rare in the Asian population. Protein S deficiency is it's a vitamin K dependent anticoagulant protein which is activated by protein C to ultimately decrease the conversion of prothrombin to thrombin. And a diagnosis of protein S deficiency is more reliable when evaluated in a non-pregnant woman. So basically, protein C deficiency and factor V latent can be screened for. But in general, when you look at the screening guidelines, for RPL, screening is not recommended for hereditary thrombophilia, except in the context of research. So don't screen for inherited thrombophilia in a case of a RPL, unless that patient has history of mid-trimester losses, because then you can think, oh, it could be one of the inherent thrombophilias. But then the question arises, does heparin and aspirin work in inherent thrombophilia? One prospective randomized trial, the live birth rate for women treated with enoxaparin was 86% compared with 29% in women taking low dose aspirin alone. And the conclusion, which many studies have given, that heparin therapy during pregnancy may improve the live birth weight of women with second trimester miscarriage associated with inherent thrombophilias. But there is insufficient evidence to evaluate the effect of heparin on pregnancy to prevent miscarriage in women with recurrent first trimester miscarriage associated with inherent thrombophilia. So technically, what I'm trying to tell you is, second trimester abortions, yes, think of inherent thrombophilias. First trimester abortions generally is not because of inherent thrombophilias, so we need not screen for them. Okay. So basically, let's come to some clinical situations. A 36-year-old multipara presents early in labor at 5 a.m. She has history of DVT. Remember, she's got history of DVT at 28 weeks of pregnancy and is on therapeutic doses of low molecular weight heparin. The last dose was at 8 p.m. last evening. The current gestation is 35 weeks and her previous 2 deliveries both were induced for post-maturity. The cervix is effaced but not dilated and she is demanding a epidural. What are you going to do? Are you going to check the APTT levels, and if normal, she can have an epidural? Yes, you probably can do that. Advise her it is fine. She can have it after 8 a.m. if she labors. No, because here it is, she's already had a DVT and she's on the full dose of low molecular weight heparin. She's not in that 40 milligram dose. So you can't wait only for 12 hours and give her an epidural. Advise her that it would not be safe to insert an epidural until 24 hours after the last dose, which is not to inject anymore, and admit and observe her. So that means stop her heparin and admit her and observe her and see what happens after 24 hours. And if she goes into labor after 24 hours, one can give her an epidural. Admit her and change to unfractionated heparin. Yes, one can do that also. And advise her to have no further heparin till after delivery to reduce the risk of bleeding. Well, false, because here she may not go into labor and she may wait for the next 6-7 days, which we don't want to do in a case with DVT. So this is how one has to think and apply when to start and when to give heparin. So according to the American College of Chest Physicians, in women with history of antiphospholipid antibodies and previous history of pregnancy loss, it is recommended to use prophylactic doses of anticoagulation. Whereas those with inherent thrombophilia and previous history of pregnancy loss, it is less clear-cut if anticoagulation should be recommended. For women with thrombophilia and a history of late fetal loss or stillbirth, presental abruption, or fetal growth delay, the use of anticoagulation should be reviewed on a case-to-case basis with no clear-cut recommendations for its use. So I believe this slide makes it all very clear when to use heparin and for which case. Some under conditions where heparin is used is an IVF pregnancy. People are now giving it after embryo transfer to help the implantation to occur, or in hyperstimulation syndrome, of course, sometimes. And of course, use of heparin in obese patients to prevent a post-operative DVT. But I think what we needed to know is when to use it in recurrent pregnancy loss and how to start and how to do it. Thank you all very much. And this is this is something which I had done when I was the ICOG chairman. We made a series of 20 minutes on the great people who were there, who have contributed to the subject of OBGY, Indians who have done it. We have labeled as Diamonds Are Forever. There are clips on Dr. V.N. Shidorkar and 4 others. So please definitely go to the ICOG website and search for Diamonds Are Forever. Have a look at those clips. You will enjoy them. Or go on YouTube and search for Diamonds Are Forever, and you can type ICOG, or you can type Dr. B.N. Shidorkar or Dr. B.N. Purandare. And we have on Dr. Shivkar and on Dr. Patwardhan. These 4 clips are there. I'm sure you will enjoy it. I just said, let me take this chance to convey this message to you. Parag has contributed a lot to this series also. So thank you very much for a patient hearing. Okay.
Thank you, Dr. Uday. Can you hear me?
Yes, I can hear you, please.
Yes. Well, it has always been so-called nice to listen to your lectures. I remember the old lectures given in Amritsar and elsewhere also. Messages are very clear, very truly. This matter had been very tricky and still debatable. So many views come to you whether to start, not to start. If you start, when to stop, how to stop, and so many things, because you keep reading and you keep getting confused. But today's lecture was very clear. There are some guidelines which we can follow. Well, very crisp messages you have given. Good, we've seen you also and heard. Thank you so much. Thank you so much.
Thank you. Thank you, ma'am. Thank you.
Vidhu ma'am?
Yeah. So, yeah, it was very excellent talk. Dr. The messages were absolutely clear what we need to do. Because the other day somebody was asking me, हमें heparin लगाना चाहिए कि नहीं post cesarean to or almost after every surgery. So I just want you to let the audience, should we give post surgeries to all our patients?
No. One has to give it only to patients who you feel are at a high risk of DVT, like the very obese patients, so you already have a history of DVT. Yes, those patients. Now, even in patients whom we have started aspirin and heparin for obstetric reasons, normally we don't continue heparin, but technically they say continue till 6 weeks post-delivery to prevent a deep vein thrombosis. But normally in practice, we really haven't been doing it. All our patients who are on aspirin and heparin, we stop them at around 30.
Patients who are APLA positive, we continue them 6 weeks post-delivery also.
And once we deliver them, we don't put them on aspirin, we don't continue heparin. So technically speaking, the 6 weeks tak heparin dena chahiye. So that for only pure obstetric APS, I think it is good enough to think. And of course, we can start them on aspirin and keep them on aspirin for a longer time. If she has a history of DVT, 100% she requires heparin till 6 weeks. If she's got a history of DVT in the past.
Thank you.
So thank you so much, Uday sir, for sparing your precious time and definitely sharing this knowledge. Definitely is very, very helpful. This topic is much needed and there is a lot of confusion. So this was the most needed topic and you clarified all our doubts. Thank you so much.
Thank you very much. Thank you. I really appreciate it. Thank you.
Thank you, Uday sir, and thank you, chairpersons, for this excellent talk. We move forward to the next topic, that is cholestasis and pregnancy by Dr. Geeta Balsarkar, madam. Our chairpersons for today's session, Dr. Rama Sopat, madam. She is a retired professor and head of the department. As started the colposcopy unit in Punjab in 1985, and she was the first one to start hysteroscopy as well as operative laparoscopy in Punjab in 1990. She has been designated as the Women of the Year in 2000 by the American Biological Institute, USA, and awarded the MNAMS by the National Academy of Medical Sciences in 96. We welcome you, ma'am, as a chairperson. Dr. Preet Kanwal Sivya is a professor in Department of Obstetrics at GMC Patiala. She has a teaching experience of 20 years and she is an undergraduate and postgraduate teacher with more than 50 publications. She is currently the secretary of Nabha Obstetrics Society and she is a master trainer for BMOC. She is also the member of the GMC curriculum committee and the resource faculty of BCME course for faculties. Her special interests include high-risk pregnancy, emergency obstetrics, and infertility. We welcome you, ma'am. Our next chairperson, Dr. Manjeet Singh, is the current president of Bathinda OBGYN Society. He is also next person of AFMC Pune. His special interests include advanced vaginal and laparoscopic surgeries, and she is also a member of various associations. He is the director of Preet Hospital at Bathinda. We welcome you, sir, and we request you to please introduce our faculty, Dr. Geeta Balsarkar, madam.
Who will do the me?
Manjeet, sir, yes. Rama madam is there, ma'am. Rama ma'am, can you introduce madam?
Yes.
I think Dr. Manjeet Singh can introduce Dr. Geeta. Madam will make the concluding comments. No problem.
Our speaker for the next section is Dr. Geeta Balsarkar. She is the editor emeritus Journal of Obs and
Yes, please go ahead.
Secretary of Obs and President Association Medical Women in India Society Obsi 2002. For us in 2008 and George.
Sir, sir, I'm I'm at Wadia, sir, and I'm a professor and I have a unit. So I need all the three chairpersons blessing. All of you all are senior to me. I need the blessing. So I'm going to talk to you today about something that is intrahepatic cholestasis in pregnancy. So this is something which is, often seen. This is a clinical scenario that we get in this patient: normal pulse, BP, heart, lung, no abnormalities, no hepatosplenomegaly, and absolutely normal looking patient. But then this patient comes to you with severe itching. They are not able to tolerate the itching. The itching starts especially in the night. But if we see the incidence, it varies from less than 1% to 27.6% worldwide. It is different in different parts of the world and different in different parts of the country also. In the United States, it's 0.32 in Bridgeport Hospital and Connecticut to 5.6 in some Hispanic population in Los Angeles. Across Europe, the incidence ranges from 0.5 to 1.5%. In India, Asia, and Pakistani Asian populations, the incidence is 1.2 to 1.5%. It is known to have a seasonal occurrence also and some risk factors. For unknown reasons, the disease occurs more often in the winter months in some countries where the skin also tends to become a little dry. So coming to the etiology, it is an etiology of familial clustering, increased risk in first degree relatives. So if you ask this patient, do you have any first degree relative who has got this particular problem, that is of severe itching, increased risk in some ethnic groups, and a high recurrence rate, 60 to 70% recurrence rate in the same patient. If she has had it in previous pregnancy or the pregnancy before that, then there is a very high recurrence rate. Intrahepatic cholestasis of pregnancy occurs very typically in the second half of pregnancy. These patients are very comfortable in the first half of pregnancy. It occurs in the second half of pregnancy when concentrations of the estrogen reach very high levels. Low selenium levels due to the diet, like plant-based diet in a region with low selenium levels in the soil, are supposed to be a contributing factor. And low levels of exposure to sunlight has also been implicated in intrahepatic cholestasis. So we can think that, selenium supplementation or whether vitamin D supplementation could help, but there is no study to that effect. A small subset of individuals with intracolate this has an identifying underlying liver disease, which may be revealed by pregnancy, and it contributes to development of the cholestasis in pregnancy. Therefore, each and every patient who presents to us with intrahepatic cholestasis, we have to rule out the underlying liver disease or the underlying pathology. Though it is seen in very few patients, majority of them, it may be simply pregnancy associated, but still it is in one sonography, you can do a abdomen along with the pregnancy sonography. You can do an abdomen sonography and have a look at the liver and the gallbladder. Estrogen and progesterone, why do we say they are responsible for why do we say that they are responsible for causing the cholestasis of pregnancy? Because it is more common in twin pregnancies, which are associated with high levels of circulating estrogen than in singleton pregnancies. It's reported little early pregnancy after ovarian hyperstimulation, which results in markedly high serum estrogen levels. And the cholestasis of pregnancy resolves in the days following delivery. The moment the patient has delivered, in 1 or 2 days, they can be seen sleeping so soundly and snoring because they have not been able to sleep in the past 3 to 4 months, because placenta, which is the major source of estrogen production across the second and third trimesters, it has been come out. Therefore, it gets relieved. The itching gets relieved after the delivery. Now, estrogen and progesterone, cholestasis occurs in individuals taking estrogen, progesterone contraceptives. The increased risk of the intrahepatic cholestasis of pregnancy is unknown, though exogenous progesterone supplementation during pregnancy, like the hydroxyprogesterone caproate, reported 8% incidence of pruritus in treated patients and listed cholestatic jaundice of pregnancy and liver tumors, benign or malignant, or active liver disease as contraindication to the therapy. Now, how do they present? They typically present with pruritus, which ranges from mild and then it gradually increases to become intolerable, often generalized, but generally starts predominantly on the palm and sole and is worst at night. Right upper quadrant pain could be there, nausea, poor appetite, sleep deprivation because of itching, and steatorrhea. These are the other signs and symptoms that are associated with cholestasis of pregnancy. Transient first trimester symptoms have been linked to ovarian hyperstimulation syndrome after IVF. Though nowadays we are doing frozen cycles only. Fresh cycles are rarely done. But when the fresh cycles used to be done, we used to see very commonly ovarian hyperstimulation after IVF, and then we used to see this cholestasis of pregnancy. But however, encephalopathy or other stigmata of liver disease, if present, we should search for other causes of the liver disease. In the physical examination, when we see the patient, we will see stretch marks, scratch marks, there will be excoriation and prurigo nodules secondary to scratching. Jaundice occurs in 14 to 25%, typically developing 1 to 4 weeks after the onset of itching. Jaundice without pruritus is rare and should prompt investigation of the other causes. In cholestasis of pregnancy, it presents as pruritus, and 25% of patients can have jaundice. But if patient comes to you with jaundice and then pruritus, then we should think that there should be some other cause for this. Lab findings, you will get elevated bile acids and bilirubin, and so total serum, total bile acid concentration is increased, present in 90% of the affected pregnancy. Pruritus may precede lab abnormalities. Total and direct bilirubin concentration are increased in 25% of the cases. Serum aminotransferase increased in 60% of the cases, usually less than 2 times the upper limit of normal, but it can reach values greater than 1000 units per liter. Making distinction from viral hepatitis is very important in these cases. Alkaline phosphatase increased possibly 4-fold, but this is not specific only for cholestasis, because it can be seen in other pregnancy condition also because of the presence of placental isoenzyme. So this is a differential diagnosis diagnosis, like it could be pruritus gravidarum. In this case, the pruritus comes only in the third trimester. It is not seen in the second half of pregnancy. Similar presentation to intrahepatic cholestasis of pregnancy, but the liver function test and the bile acids are completely normal in these patients. Atopic eruption of pregnancy, pruritus is seen right in the first trimester. Dry, red rash with or without blisters typically affect the trunk and limb flexures. Polymorphic eruption of pregnancy, pruritus in the third trimester, typically affects the abdominal striae with umbilical sparing. Urticarial papules or plaques and vesicles and target lesions are there. Then pemphigoid gestationalis, itchy rash in the second and third trimester. It's an autoimmune condition characterized by complement fixing immunoglobulin G antibodies. A rash develops into large, tense blisters associated with increased risk of preterm delivery and SGA, recurs in subsequent pregnancies, and also combined oral contraceptives. If the patient is given, they get this pemphigoid gestation. Prurigo of pregnancy. Prurigo is usually in the third trimester. Groups of red-brown papules on the abdomen and extensor surface of the limbs. They may persist postpartum. Pruritic folliculitis of pregnancy is pruritus in the third trimester, and aniciform eruptions on the shoulder, upper back, thighs, and arms. Papular follicles and pustules, which may be filled with pus, but culture is typically sterile. Rash improves with advancing gestation. So the liver function is a very, very important thing when any patient presents to you with itching. And if the liver functions are abnormal, kindly consider doing an abdominal sonography along with your obstetric sonography. So other differential diagnoses which are very, very, very important to the acute fatty liver of pregnancy, they will have nausea, vomiting, headache, abdominal pain, and the new nausea and vomiting the third trimester are never caused by hyperemesis gravidarum. Women with the acute fatty liver of pregnancy have more unwell and are associated with renal impairment, coagulopathy, hypoglycemia, and preeclampsia. Hemolysis, elevated elevated liver enzymes, and low platelets. They have hypertension, proteinuria, headache, epigastric pain. Hypertension and proteinuria are predominant features. Hyperemesis gravidarum is exclusively seen in the first trimester. Presentation early in pregnancy. Abnormal liver function could be seen, but that resolves with the successful treatment. So the other pre-existing causes before the patient becomes pregnant, if she has viral hepatitis, if she has primary biliary cirrhosis or primary sclerosing cholangitis, autoimmune hepatitis, drug-induced liver injury. Many of our patients take homeopathic and allopathic medicine sometimes. They don't tell us till we point blank ask them what they are taking. That can cause drug-induced liver injury, biliary obstruction, veno-occlusive disease. All of these are differential diagnosis of the severe itching in pregnancy. But of course, these are pre-existing conditions before the patient has become pregnant even. Now, does it have any effect on the fetus? Yes. The main complication is increased risk of fetal demise, meconium staining of the amniotic fluid, preterm birth, and neonatal respiratory distress syndrome. The magnitude of the risk, all adverse outcomes are increased, like iatrogenic preterm, when we deliver the patient for the sake of the mother, spontaneous preterm, meconium stained amniotic fluid, NICU admission, stillbirth, all are increased in intrahepatic cholestasis of pregnancy. And the risk of stillbirth increases with increasing serum total bile acid levels, especially if they are more than 100 micromole per liter. Less than 40 micromole per liter is 0.13%, 40 to 99 is 0.28%, and more than 100, 3.44%. So the maternal treatment, the management of intrahepatic cholestasis of pregnancy has two main goals: reducing the bothersome symptoms of the patient and reducing the risk of perinatal mortality and morbidity. So what do we start? The first line is ursodeoxycholic acid. Ursodeoxycholic acid. Optimal dose for starting is 300 milligram 3 times a day, or 15 milligram per kg per day until delivery, or 300 milligrams twice daily. We can start, or 3 times depending on the patient's body weight. It is well tolerated in majority of patients. They will immediately say within 24 to 48 hours that the itching has gone down, but mild nausea and dizziness have been reported. Decrease in pruritus is gradual gradually seen within 1 to 2 weeks, and biochemical improvement in liver function test is seen within 3 to 4 weeks. Pruritus is not relieved to tolerable level, then it can be titrated further and the dose can be increased. Now, the efficacy, what is the evidence efficacy? There is a meta-analysis of ursodeoxycholic acid versus placebo. And then they have said there is modest improvement in maternal pruritus on a 100 millimeter visual analog score. There is only one death which was reported, maternal death, which could be probably because of a misdiagnosis. And there is a non-significant trend towards reduction in NICU admission. However, it's not significant, non-significant trend toward reduction in spontaneous preterm and non-significant trend toward reduction in total preterm. Therefore, treatment will be only relieving the symptoms. It might improve mother's liver function, but the chances of preterm will not be altered by treating with ursodeoxycholic acid. Treatment and post-treatment lab monitoring before treatment. No additionally laboratory tests need to be done. We have already done a liver function test. Follow-up bile acid levels. We can do clinical decision making is based on the highest total bile acid level at any point during the pregnancy, maternal obstetric history and symptoms. Repeat evaluation of maternal total serum bile acid concentration can be considered weekly due to significantly increased risk of stillbirth in these patients with total bile acid concentration more than 100 micromole per liter, and which would favor early delivery. So if we are deciding to wait on these patients also, we may have to repeat the total serum bile acid concentrations every week. So there are some refractory cases. L-adenosyl methionine has been tried in these cases, cholestyramine, even rifampicin. I have also given 1 or 2 patients rifampicin because it is a hepatic stimulant. So it relieves pruritus in non-pregnant patient with pruritus associated with cholestasis, but a lot of adverse effects like nausea, decreased appetite, hemolytic anemia, renal failure, hepatitis. So these are the other drugs which can be used in refractory patients. The other drugs like hydroxyzine, chlorpheniramine, that is 4 milligrams orally every 4 to 6 hours, has been used to treat pruritus with minimal efficacy. Calamine local lotion and aqueous cream with 2% menthol may also relieve pruritus. Dexamethasone 12 milligram orally per day did not improve pruritus or reduce the serum aminotransferase level and was less effective than the ursodeoxycholic acid at reducing bilirubin and bile acids in a trial. So pregnancy management, antepartum fetal monitoring is very, very important. We have to follow all pregnancies with intrahepatic cholestasis of pregnancy with twice weekly modified biophysical profile, non-stress test, AFR. So timing of delivery is very important. What is a patient's highest bile acid concentration at any point during pregnancy? If it is more than 100 micromoles per liter, we have to deliver these patients. If it is 40 to 99, with strict monitoring, we can deliver these patients between 36 and 37 weeks. If it is less than 40, then you can do a conservative management on these patients on treatment with ursodeoxycholic acid. So the timing of delivery is very important. Total bile acid concentration less than 40. When the highest bile acid concentration is less than 40, delivery between 37 and 38 weeks. But please do not wait till 40 weeks on these patients. Total bile acid concentration 40 to 99. Then the 36 to 37 weeks delivery is indicated. And that bile acid concentrations more than 100, then we suggest delivery at 36 weeks. Or if your institute has got good outcome of babies at 34 weeks, then we can 34 to 36 weeks we have to deliver these patients. Excruciating and unremitting maternal pruritus is not relieved with pharmacotherapy. Worsening hepatic condition is very, very important to be identified. Prior history of fetal demise below 36 weeks with ICP and recurring ICP in the current pregnancy, these patients are very, very high risk of having again another IUFD. So what does RCOG says? Peak bile acid 19 to 39, no other risk factors. Risk of stillbirth is similar to the background risk. Option include planned birth before 40 weeks. Anyway, do not become overdue and ongoing antenatal care according to the national guidance. 40 to 99, no other risk factor. Still background until 38 to 39 weeks. We have to consider planned delivery 38 to 39 weeks. For peak bile acid concentration more than 100 micromoles, the risk of stillbirth is higher than the background risk. We have to consider planned birth 34, 35, 36 weeks of gestation. ACOG, Society of Maternal Fetal Medicine, all of them says that for patients with total bile acid less than 100, delivery is recommended 36 to 39, or sometimes the diagnosis at 39, then you have to deliver the patient immediately. For patients more than 100 micromole, delivery is recommended early, 34 to 36 weeks, or whenever it is diagnosed. What is the maternal outcome? In postpartum course, pruritus disappears in the first few days after giving birth, accompanied by normalization of serum bile acid concentration, liver tests. Represented for the maternal and infant benefits, it's not a contraindication to breastfeeding. Ursodiolic acid is discontinued very big and need not be given in the puerperium. Only small amounts will be ingested by the infant. It is not any adverse effect in the breastfed. Follow-up, check liver biochemical test and bile acid concentration after delivery if the patient is symptomatic. If lab abnormalities do not return to normal, this patient should be referred to a hepatologist to assess the underlying hepatobiliary diseases. Special populations, patients with cirrhosis, patients undergoing ovarian stimulation, patients receiving progesterone supplementation. These are all very special patients. They are prone to have preterm births because of intrahepatic cholestasis of pregnancy. We need to manage their underlying condition in addition to the intrahepatic cholestasis of pregnancy. So the take-home message is diagnosis of ICP is based on pruritus associated with elevated total serum bile acid levels, elevated aminotransferase, or both, absence of diseases that may produce similar lab findings. Pruritus begins in the second or the third trimester, ranges from mild to intolerable, primarily affects the palm and sole, and is worse at night. It can precede the rise in serum bile acid by several weeks. Severe cholestasis is defined as bile acids over 40 and accounts for 20% of the cases. Pruritus helps distinguish intrahepatic cholestasis of pregnancy from other types of pregnancy-related disorders characterized by elevated SGOT levels like HELP syndrome and the acute fatty liver of pregnancy. Lack of primary skin lesions in intrahepatic cholestasis of pregnancy helps to differentiate it from the other pregnancy specific pruritic dermatosis and skin conditions unrelated to pregnancy. The fetal effects, the major complication are fetal and neonatal, increased risk for IUFD, meconium, staining, preterm birth, neonatal respiratory distress syndrome. The risk of stillbirth is highest when total bile acid concentration is more than 100. Ursodecolic acid relieves pruritus, no known fetal toxicity, well tolerated, 300 milligram 2 or 3 times a day till delivery is reasonable. If it is started empirically, elevated bile acids and aminotransferase levels may never be detected. Therefore, it is better to start when either the liver function becomes abnormal or the bile acid increases. The timing of delivery is generally based on the highest total serum bile acid concentration at any time during the pregnancy. We have already discussed the 3 levels, less than 40, 40 to 99, and more than 100. Pruritus and lab abnormalities resolve after delivery. Liver function and bile acid concentration should be rechecked if the patient continues to have clinical symptoms after delivery, and we have to revisit the diagnosis and refer this patient to a liver specialist. Cholestasis occurs during subsequent pregnancies in 60 to 70% of the patients. Recurrent episodes are variable in severity. Thank you for a patient hearing.
Yes,
you.
ma'am.
Ma'am, you are audible.
Thank you, Dr. Geeta, for a very crystal clear presentation, particularly detailing out the detailed differential diagnosis, and the management has been very well covered by you. As for the attendees, the take-home messages have been elaborated by Dr. Geeta, but I would like to add that one should have a high index of suspicion, and not only to diagnose it, but also to differentiate it from other conditions related to pregnancy pruritus, and by ruling out other causes of pruritus. As regards the serum bile acids, I would say that I have some reservations. The test is very costly, 2,500 by Ranbaxy Laboratories, and the report comes in 3 to 4 days. So for the class of patients that we are mostly dealing with, I would like to ask you whether aminotransferases and other tests could be a substitute after the initial total bile acid estimation?
No, madam. If once you will have to do at least after 6 weeks to see that it has come down to normal. If it still persists, that means she has got some other pathology, and we need to be very clear about it. But unfortunately, the bile acids only in intrahepatic cholestasis of pregnancy, the bile acid only SGOT, SGPT may or may not rise fourfold. So they are not very specific for this, but we will have to do the bile acid only.
Okay. And then some of the papers say that it should be a non-fasting estimation of serum bile acids, and others say it should be with a fasting condition.
Madam, my husband is a surgeon, so I have often discussed the case with him. So they say that along with the other blood test you can do, fasting is better, and there is no need to do non-fasting. That is what they say. You can do it along with the other blood tests. Whatever if the patient has got symptoms of itching.
The patient cannot afford repeated bile salt examination.
One study, one when she has got symptoms, and one after 6 weeks to ensure that it has gone down.
After delivery, 4 to 6 weeks after. And then could we make it a blanket coverage of delivering the patient at 36 to 37 weeks?
Madam, it depends on your setup. That where if you have got even 34, 35 weeks, sometimes you have had to deliver, because these patients they are sitting in the ward, even if they are admitted, and they are continuously itching. And sometimes, the mother herself will request that you just deliver me and relieve me. So, sometimes we have to take that decision. Not necessarily only because of the blood test and because of our liver condition, but even otherwise because of our symptoms. Sometimes, they are not ready to wait. My patient they fall at my feet, kuch bhi kar, but you just relieve me or deliver me, That is the whole situation. So we can take a call. It is individualized, highly individualized according to every patient. You can see whether if she itching wise, she's comfortable, whether she is what about the baby, the NST, liquor, sometimes meconium also comes in these patients. Anyway, liquor is high could be high colored also in these patients, yellow colored also.
And there are very variable suggestions from RCOG, this Society for Maternal and Fetal Medicine, and American College, though it is not very recent, the American College report. And it has said that the UDCA is very effective in reducing or improving the perinatal outcome also. Thank you very much.
Yes. No, perinatal, they are not saying, madam. They are saying patient symptoms and liver function will improve. But perinatal, they are not saying. The perinatal will remain. The basic problem is of increased bile acids. So the preterm and perinatal outcome, even IUFDs have been reported even when patient's liver function is improving.
Yes.
Dr. Geeta, excellent presentation. I want to ask one question. In refractory cases, as you are saying, I am giving rifampicin. What is the dose and what is the duration of therapy?
See, just rifampicin is to just stimulate the liver to help clear the bile acids and, to prevent the itching. So like what we give in AKT, that whatever the dose of the rifampicin, same I have given. And I just, with the help of, all physicians and everything, because there was nothing else we could do to pull this patient for some more time, 7 days, 10 days, I have just given, and then I have just delivered the patient.
Okay, thank you so much.
It's a hepatic stimulant, so,
Yeah.
I hope the queries are clarified, and that was really excellent talk, Dr. Geeta. Thank you so much for spending your valuable time, and of course, wonderful presentation. Thank you so much.
Thank you.
Thank you, Geeta ma'am, for an excellent presentation with very good take-home messages. And I thank all our chairpersons for sharing the session and accepting our invitation. We now move forward for an excellent panel discussion on hyperglycemia in pregnancy. Our moderator for today is Dr. Sneha Goyal, madam. Madam has been introduced earlier. So, ma'am, can we
Yes,
go
go
ahead with the introduction of our experts, Dr. Kavita Bhatti, madam, and Dr. Sangeeta Pahwa. Kavita Bhatti, madam, is a professor and head of the department at GMC Ludhiana, and she's
They
currently the
have been
vice
also
president.
introduced, Monica. They have
Yes,
been
ma'am.
introduced in the inauguration. You can go ahead with the introduction of panelists.
Yes.
So I welcome both my experts, Dr.
Good.
Kavita and Dr. Sangeeta.
Thank you so much, ma'am.
Let us go to the introduction of our panelists. Dr. Sushmila has over 15 years of experience in obstetrics and gynecology. She manages high-risk pregnancies at her center, and she's been trained in states of Gujarat, Rajasthan, and Punjab with an experience of more than 10,000 vaginal deliveries. Ma'am also has been working at Surat. She's a consultant at Escorts Jodhpur for 1 year, and she's also at the consultant at Dr. JBL Bessie Hospital, Ludhiana, for the last 14 years. We welcome you, ma'am.
Yeah.
Our next panelist is Dr. Satinder Pal Kaur, ma'am. She's a professor and department of the head of at GMC Patiala. She's also a trainer of BMC, a nodal officer for PPT-CT program at GMC Patiala, examiner for DNB and undergraduate exams. She's also the joint secretary of Nabha OBGYN Society. We welcome you, ma'am. Our next panelist is Dr. Nidika Chhabra, ma'am. She has done her MBBS from Shimla, Himachal Pradesh as a university topper and a gold medalist. She currently is a consultant at Chhabra Hospital, Ludhiana, since last 2007. She has to accredit few papers and poster presentations at national and international conferences. Her special interests include infertility and high-risk pregnancy. We welcome you, Nidhi, ma'am. Our next panelist is Dr. Preeti Dev, madam. She is a life member of PCOS Society and an IRC certified colposcopist. She is the secretary of Amritsar Menopause Society, and her areas of interest include preventive gyno-oncology, menopause, and high-risk pregnancy. Our next panelist for today, Dr. Sandesh Kachu, madam. She's a professor at GAGM-SCH Faridkot, an executive member of KFOGS, peer reviewer of ACOG FMF. She's been an examiner for postgraduate and DNB exams, more than 20 research publications and 15 papers and conferences. We welcome you, ma'am, as a panelist. Dr. Shail Kaur. She's a professor and in charge of high-risk antenatal unit at the Punjab Institute of Medical Sciences, Jalandhar. She's also a member of the FOXY Medical Disorders and Pregnancy Committee, academic chairperson of FOXY Jalandhar, the former editorial board of FOXY Sexual Disorders Committee, and publications in various journals. She has also contributed chapters in books, and she has been a faculty at various conferences. We welcome you, ma'am. Over to you, ma'am, for the panel discussion.
Yes, thank you so much, Monica, and a very good evening and a warm welcome to all the panelists. Without much ado, I think we should straightway go to our panel discussion. So once again, I welcome Dr. Shumalia, Satinder, Dr. Nidika, Dr. Preeti Dev, Dr. Sandesh, Dr. Pooja, and Dr. Shail Kaur. So I hope you can see my presentation and it is full screen, right? So please bear with my voice. It is little down today. So just maybe it will be cranky sometimes. So I would just start the presentation with the facts that yes, India is known as the diabetic capital and the population is growing. May it be type 1, type 2 or gestational diabetes, about 60 million women of reproductive age group worldwide, they have diabetes mellitus, and this figure is supposed to be double by 2030, and that is too much. So at least 40% of these diabetic pregnancies, they are unplanned, and you can make out what problems, what disasters they will land up with. So I'm sure all of us are very clear that it is the hyperglycemia which is diagnosed for the first time during pregnancy, whether she is treated with MNT or medication, insulin or metformin, whether she, it reverts back to normal or no after the delivery. We still label this as gestational diabetes mellitus. 2 out of every 5 women with diabetes of reproductive age group, they account for this reproductive age group. These are the women, 60 million I have already said. that these are the 60 million women who are diabetic. These women belong to the reproductive age group, and the prevalence of hyperglycemia increases rapidly with age and is highest in women over the age of 45 years. So Shumalia, we start from you. Why are we worried so much about this hyperglycemia? Does it really have a very high impact on the maternal or the perinatal outcome or the pregnancy outcome per se? Dr. Shumalia? Do we have Dr. Shumalia? Okay, so we can immediately the next person can take up. Yes, I would like to also rename yourself. Yeah, please go ahead. Why are we worried about? Anybody? Yes, I can see.
Yes, ma'am. Yes, yes.
Please
As you
go ahead.
said, ma'am. Yeah, I'm Dr. Sindar. As you said, ma'am, because India has become a diabetic capital, so it is very, very important for all us to foresee this fact that hyperglycemia in pregnancy is to be taken very, very seriously, because it leads to a lot of perinatal and maternal morbidity and mortality. And from various areas, the prevalence of hyperglycemia in pregnancy has been as high as around 5 to 18%. And it causes many acute and the chronic complications, and there has been around 4 to 5% mortality due to very, very acute complications like diabetic ketoacidosis. So it is very important that we have to take this disease very seriously. And second, what are we worried so much about? Yeah, we are worried so much about it because it is not only the later outcome in the child or the baby. We are worried about immediate maternal morbidity, mortality, and immediate perinatal morbidity and mortality, which is the thing, because if we screen them properly, if we diagnose them properly, treat them properly, then we can have a very good outcome.
Right. So definitely, I would like to ask you, are these, I mean, without now discussing the theoretical aspect, I'm sure you all are well versed with my panel discussion. We don't want to discuss the theoretical aspects. We want all of you to be expert in the practical management. That is how only we can, manage our patients, reduce the morbidity as well as mortality. So, Satinder, we continue with this, you only.
Yes.
We have this 22-year-old young lady. She comes to you for first antenatal checkup at 10 weeks of gestation. When you examine, she is, her height is 152 centimeter, her weight is 69, her BMI is 30. So does she need to be screened for diabetes or hyperglycemia in pregnancy? She doesn't have family history of diabetes.
Yes, yes, and yes. Now, there were lots of deliberations way back because there were lots of ethnic differences, there was a lot of infrastructure differences. So DIPSI came out with the idea that yes, for Indian setup, it is mandatory that we have to do universal screening at any point of the time patient comes to it, maybe as
Dr.
early as 10
Satinder,
weeks.
I would agree. I mean, I fully agree with you. Yes, yes, and yes. But I would interrupt you here to say that just because she is having high BMI, you want to go for, or you have something in your mind to clarify that why you should screen her. Yes.
Yes, because she may be a patient of pre-gestational diabetes. So that is the importance. I want to screen her even at 10 weeks, because there are many patients who may be a patients of pre-gestational diabetes, which can be screened at early age. And this has been now corroborated by WHO, by Government of India, by the other societies like FIGO and IDF also. So I will 100% go that yes, she should be screened, and if she is negative, then I'll go for repeat screening in the second trimester after 24 weeks. Again negative, so, I can go in the third trimester also.
Just to deliver some messages, I would say yes, and you will go for screening, and it will be a universal screening as a part of the universal screening. That means every woman during every pregnancy, right?
Yes.
So you're very right here in screening. Now, how and when. Now she has come to you, so this is her first ANC visit. So you will utilize this window of opportunity and screen.
Yes.
So how do you
Yes.
screen this lady? Which method you will screen? How do you interpret the test?
So is
Yeah,
it
sorry.
What screening test and how do you interpret the test?
is it for the next panelist
Yeah,
or
that's
for
for
me only?
me. Yeah, that's
Yeah.
for me, Dr. Sindar.
Yes.
Yes. Madam, as you advocated, universal screening at the first point of contact is universally practiced now. We should all practice that. So I would like to go for the 75-gram DIPSI test, irrespective of the last meal she has taken. I'll do the 75-gram glucose challenge test, in which we make the patient drink 75 grams of glucose in around 250 to 300 ml of water, which is to be consumed over 5 to 10 minutes. And at the end of 2 hours, plasma glucose level screening is done. And if the levels are above 140 milligram per deciliter, it is diagnostic of GDM. And in case sometimes the patient tends to vomit, and that is a very common practical problem which we encounter. If the vomiting happens within 30 minutes of ingestion, we have to repeat the test after, say, 2 or 3 days.
Test on that day and repeat, call her on this number.
Repeat. Call her the next day or maybe 2-3 days thereafter. But if the vomiting happens after 30 minutes of ingestion, then we can go ahead with the tests as per routine. So that is what I would like to do, madam, for her.
Yes. And how do you interpret? That is what I've said. You said that 140, more than 140, she screened positive.
Yeah, madam. If it is, if the value comes above 200, that means she is definitely a candidate for insulin administration. But if the value comes above 140, I would like to try her on maternal nutritional therapy and exercise for the coming 2 weeks and call her for a follow-up after 2 weeks.
First and foremost, definitely you will not go into the confusion whether you will follow SCOG, RCOG, NICE, this, that. You don't even need to, because you don't have to appear for the MDMS exam now. It's only the practical, what you will use for your patient, and that's a single step 75-gram OGCT, very clear. First test has to be done at 24 to 28, first test at first ANC visit, and second at 24 to 28 weeks. And definitely, if you have GGI, that is why I was asking you about the interpretation. If you still have a doubt or a high risk, then of course you will even repeat the test at 32 to 34 weeks. So when you talk about the interpretation of the test, it's not only the how to do this test, we have already said, and all of you have discussed, and then how to interpret. See, so 140, more than 140, yes, GDM. Less than 120, normal. More than 200, you said it, that it's a case of over diabetes. What about in between? So 120 to 139, you label them as GGI. Why? Because you have to have your eye on these patients. You tell them, give them some diet modification, because these are the ones which will, as the hormonal levels, the anti-insulin hormones goes up at the end of the second and the beginning of third trimester. That is a time where these can become it can be frankly again GDM. So that's the reason you have to give them diet advice and repeat the test between 32 to 36 weeks. So gestational glucose intolerance. Now, I would just, what is this lady, she comes to you with a report of fasting blood sugar level, and that is 86, and HbA1c. Dr. Sandesh, this is for you. Suppose this lady comes to you with a report of fasting blood sugar 86 milligram per cent and HbA1c 5.6. Does she have diabetes? Does she have GDM? How would you label her as?
So if this patient comes to me with these levels, like the fasting glucose, as you said, is 86 and the glycosylated hemoglobin is around 5.6. So all I can interpret from this is that she is not an overt diabetic. But does she have GDM or not? It has already been said that we need to get the diagnostic, OGGT test done with 75 grams of glucose, and then only we'll come to know if she is a diabetic at this point in time in her gestation.
Right. So absolutely, this is just to divert your attention. This is absolutely very clear that yes, for screening for GDM, you have to use only one test, and that is 75 grams obesity, single stage. Okay. Whatever values are there, they are of no significance for us, unless, as you said, if it is more than 200,
6.5 or more than 200, then we could label her as an overt diabetic.
Yes, correct. So this was, so does she have diabetes? I mean, we are not sure. But does she have GDM? No, because we need to screen
We have
her.
not tested her, right?
Yes. So we have to screen her, and we should do it at the earliest, right? So suppose now you do her screening and she comes as screen positive, then what do you do?
So if she is already screen positive and then we have labeled her as a gestational diabetic patient, so initially you would need to put her on a diet and exercise regimen, that is the MNT regimen, for a couple of weeks, where you would see if she is responding to this diet and exercise regimen or not. And if she is responding, she will continue on this.
What do you mean by responding?
I mean, if her blood glucose levels are within the range that are admissible, so we need the fasting levels to be, say, between less than 126, around 110, 100 to 110, 95 to 100. So if those levels are being maintained, so we'll continue her with
any difference of opinion here, Dr. Sandesh. You have taken it up to this, it is okay, but here there is a difference of opinion.
It is PPBS. It is postprandial blood sugar level. If it is more than 120, then we will definitely shift her from MNT to other pharmacological means.
Right. So the message is very clear, Dr. Sandesh, that once you label her as GDM, you give her 2 weeks time and you advise her on MNT. So what is MNT? It is a dietary modification with the calorie requirement, which is according to the RDA. That means how you should decide, we will come to the discussions later on, but definitely a diet modification where you have the right calories with right spread, and of course the active physical exercise. So you give your patient 2 weeks time, right? And then you test only postprandial, 2 hours postprandial. And if that is more than 120, then that means your patient is not under control, only with MNT. Okay, if it is less than 120, then she is well controlled on MNT and she can continue with that. That is what the management goes. So now this lady, her repeat testing, we have done initially, she was having normal things. Now at 26, when you are repeating, her results on 75 gram obesity, it is 168. Dr. Pooja. Do we have Dr. Pooja? She was, I think she was not able to join something. Okay, so Dr. Preeti. We can have Dr. Preeti Dev. Yeah. So initially she was screen negative at first visit, but at 26 weeks it is 168. So how do you go ahead with this patient's management? Do we have Dr. Preeti?
Yes, ma'am, I'm here.
Please, please.
Yeah, ma'am, since she has now come into the GDM levels, so we have to start medicines for her. Initially, we will go for oral hypoglycemics.
No. We just discussed, my dear, that even if whether at first testing or second testing, anytime the woman is diagnosed with GDM, we have to give her 2 weeks time.
Yeah, 2 weeks of nutritional therapy and exercise is to be suggested to her, and call after 2 weeks, then again do postprandial. If it is more than 120, we have to decide on whether to administer metformin or insulin.
Then only. See, that 60 to 90% of these women, they are well controlled on MNT alone. And that
because
is why
it was it was the first time she was diagnosed as deranged
26
values.
Right. So after 2 weeks, if at all her levels are well controlled, that is less than 120 mg%, she can very well go ahead with MNT alone. If it is more than 120, then only the question of medication arises, right?
Okay.
Now, if what in treatment we said that only MNT, and now when will you review her and what test you will be doing? That we have said already 2 weeks later. Now,
After
how
15 days.
evaluate? Yes.
Dipsy. Repeat Dipsy.
No, once a patient is
No.
diagnosed as positive, then how you can give her glucose? We are trying to tell her that not to have glucose, not to have any carbs for that matter, right? Once she is GTM positive, you will not give her glucose, right? It
Only
will be
postprandial.
2 hours postprandial.
Yes.
2 hours postprandial. Now see, this patient has come to you at 10 weeks and she is screen positive. You have given her 2 weeks time, and then she's suppose this patient now after 26 weeks she came as GTM positive, and then you have given her 2 weeks time. So naturally she's already in the second trimester. But suppose she comes screen positive during first trimester itself, then how do you monitor the mother and the fetus in addition to the routine antenatal care and evaluation? What investigations you want to do, especially for GTM? Who will take up this?
Ma'am, if the comes in the first trimester with a deranged glucose tolerance, I mean, even a tipsy, then the chances of her having pre-gestational diabetes, which was not diagnosed, is going to be very high.
Right.
And she has to be evaluated for all congenital malformations extensively, because she's at an increased risk of congenital malformations because of her hyperglycemia.
Correct.
And apart from that, a proper, along with medical nutritional therapy, and intensive monitoring has to be initiated right from the beginning. And as you said, we have to monitor her for the impact of the medical nutritional therapy which was advised. And and she has to be explained that this is a protocol that she's going to have to follow throughout her pregnancy, because if she has any lapses, any episodes of hypoglycemia that she has will affect the in the long term.
Right.
She counseled very extensively for that. And if there are at least 2 to 3 episodes of hyperglycemia in her monitoring chart, then she would definitely require to initiate medical therapy for her hyperglycemia.
Now, Dr. Shail, I would congratulate you saying that even if at the first visit itself, if at all she's screen positive, maybe she's having pre-diabetes. But would you not like to evaluate this mother further? You have pointed it out correctly. Then you have to do her HbA1c to see what her control was over the last 3 months. And definitely if she's a pre-diabetic, what are her systems like, whether she has any evidence of nephropathy, retinopathy, vasculopathy, all these things for the maternal interest. And then of course for the fetal interest, you have said rightly that you have to do all those biochemical and biophysical tests. Correct. Now,
Ma'am, can I just say something?
Yes, please.
Ma'am, I would also like to do a urine culture for this patient to rule out asymptomatic bacteriuria.
Yeah, that actually we are doing, Dr. Kavita, if you remember, we are doing this as a part of our routine.
Yeah. But it is important in diabetics also, so I just mentioned. And HbA1c can be used for counseling for the risk of anomaly.
Right. Now we are coming to the point. So definitely for all antenatal care ANC women, we would say that all the other tests, what we are saying, asymptomatic bacteriuria also, naturally we are going to cover everything. But in addition to this, we will definitely go for HbA1c. I'm sure all of you agree to this, because at first instance, if you find the HbA1c is more than 10, then you have to counsel the woman or rather the family that there are very high chances for congenital malformation, and we have to go ahead with the thorough investigations for this patient, not straightway for MTP, right? We will not recommend her medical termination of pregnancy, as some of the doctors, they say that. Now, I think Dr. Shail has already answered. Somebody else can take up this question. We have this primary gravida at 16 weeks pregnancy. Parents are diabetic, and she comes to you with the following reports. GCT 179 milligram %. Dr. Preeti Dev, we can have response from you. Yes.
Yes, since this is her first report, we will go for medical nutritional therapy for 15 days and look for the blood glucose levels postprandial. If they are well maintained, then we will go with that only. And if it not, then we will decide for next treatment.
Right. Do we have Dr. Nidhika here?
Yes, ma'am.
Yes, Nidhika, please put on your video. We'd like to see you.
Yeah, ma'am, my video is on, ma'am.
Yeah. So maybe I think the panel I was not able to see. Yes.
Okay, okay.
So Dr. Nidhika, what
Yeah,
is
ma'am.
your opinion on this report?
Ma'am, since her parents are diabetic and she has her first point of contact GCT as 179, so I'll definitely label her as gestational diabetes mellitus. And I would suggest her to practice nutritional therapy and simple isometric exercises, which will help in lowering down her hyperglycemic status. And I'll call her after 2 weeks' time for a repeat postprandial blood glucose estimation, 2 hours postprandial blood glucose estimation. And if I find that it is less than 120, that means whatever she's doing as dietary modifications and exercises helping her out, and will continue monitoring thereafter with blood glucose monitoring every 3rd day. So, and in case it is not controlled,
if it is less than 120, why do you want to monitor the blood glucose every 3rd day?
Ma'am, actually, we can monitor it every month also if she is compliant with the medical nutritional therapy and exercise.
Not at least every 3rd day, but maybe if she is well controlled and managing well on MNT, then maybe every alternate way, we would say every fortnightly, because it's only MNT.
Yes,
right?
2 to 4 weeks. Blood sugar level when it is less than 120 should be monitored once in 2 to 4 weeks if it is less than 120.
Correct.
In case the levels are high, then I'll switch her over to
advise them if you do it
metformin, but not metformin. She's 16 weeks. Yeah.
Okay, so the debate has started before, I think, even before I say something. I would just ask you, what is the significance? Parents are diabetic here. So is there any significance of this history here for her, especially?
Ma'am, she definitely has a higher chance of, developing. I mean, she might
She is at high risk for pre-gestational diabetes.
Right. And that is the reason, in fact, I would say you have to stress very much on the dietary modification, what MNT you want to start, that you have to be really very stringent on this. So how would you like to plan the MNT? What calories, how much she should consume, what food she should consume? How do you guide her? I think Dr. Satinder, you can take up this question.
It is very, very important because now we have decided that we have to give her therapy. It is very, very important that medical nutrition therapy has to be decided on multiple factors.
Right.
First is BMI. Second is the type of the work the lady is doing. And the third, depending upon the increased requirement during pregnancy. But as a whole, it is very, very important that we have to tell her that the amount of the carbohydrate should be around 45%, the amount of protein should be around 30%, and amount of the fat should be around 25%. This is very, very important. And she has to take 3 meals and 3 snacks. That is very important. And she has to avoid all the food which has high glycemic index. So it is very, very important that for a layman, we should give her a proper nutritional chart, which has been very nicely given by the DIPSI. So depending upon the BMI and work, there have been standard guidelines regarding that. If she's a sedentary worker, we have to give around 2250. If she is a moderate worker, it is around 2800. And if she is a heavy worker, then we can give more than 3500. And it is a very good thing which has been suggested that we tell her to divide her thali into the 3 quadrants. Half quarter should contain carbohydrate, and those carbohydrates should be heavy, which has less glycemic index. And the 1/4 of the her thali should be containing a good quantity of protein, and rest protein could be in the form of pulses if she is, and milk and milk products if she is vegetarian, and one katori of dal or chicken or fish, according to if she's a non-vegetarian. And the third quarter should have good leafy vegetables and fruit which have low glycemic index, number one. So this is the way, in a layman term, we have to tell her very, very precisely that what she has to do and what she has to avoid.
Right. So this picture, I want all of you to, we have said that, I want your opinion. Suppose your patient is not responding to MNT. She is not, coming down to less than 120. So whether you will start her on insulin or you will start her on metformin. And how do you decide that? Dr. Sandesh, I think you can take up this.
So, ma'am, we can start her on metformin with around 500 milligram of dose per day, which can be gradually increased. And again, we'll look if
does it mean for you that metformin is the first drug of choice for you?
The first drug of choice would always be insulin, the regular insulin, but the drugs available as of now are insulin and the oral hypoglycemics in the form of metformin and glyburide. Though the first choice of drug would always be insulin.
Right. So that is the reason I'm asking you that how do you decide for your patients?
Initially, ma'am, we start with insulin, regular insulin, and we titrate.
My question is only how do you decide that which patient you should prefer to give insulin and which patients you would decide to give metformin? How do you do that?
So, ma'am, we start on insulin only, and if the patient again is not responding to insulin, then only we add metformin to that patient.
Okay. Any other criteria you feel that
less than 20 weeks?
Suppose if you are giving insulin, then how many times you need to test the blood sugar?
If she's less than 20
Initially, once we start the patient on insulin,
after this, I will have both the experts' opinion. Just let me listen to the panelists.
So we'll ask her to get her self blood glucose monitoring done. So initially, like many years ago.
How many times?
Initially, ma'am, it was around 6 to 7 times. So we had both pre and post, and then we had one at 3 a.m. So we were around 7.
Three meals pre and 3 meals post. That was 6, and one very late night.
At 3 a.m. Yeah, for the smoggy or the down effect. But later it was seen that whenever the fetal macrosomia,
practically acceptable or feasible.
It wasn't practically acceptable. Right. So it wasn't acceptable, and also it was seen because the macrosomia is occurring more because of the postprandial rise in the blood glucose levels. So the pre-meals were omitted, and now we have the fasting level, the post-meals, the post-meal, the 3 major meals.
Okay.
Right.
Now let me talk to you that suppose you have a patient who is coming from a very poor family. She's staying at a remote village, and she has got this sugar levels. The report belongs to her. Now you tell me, how would you go ahead? Whether you will start her on insulin? The lady is uneducated. She absolutely doesn't know anything. And she is afraid of the pricks also. Whether you will start her on insulin or whether you will start her on metformin.
If the patient is not able to administer insulin on her own, or she may not report to me with these values very frequently, she cannot keep a check on these values, then we can put her on metformin.
That is what I wanted to say, that, what even Government of India says, that metformin is good enough in a resource poor country like India, where you do not have the healthcare provided easily accessible, where you do not have the healthcare worker to guide them and, to prick them frequently to monitor. And the level of education or even the socioeconomic status is so low that she is not able to go for her repeated blood glucose test. We are saying 7 times, 5 times, not even once, they will not be. So your patient will either land up into hyperglycemia, diabetic ketoacidosis, or maybe severe hypoglycemia. Okay. So what government says that it is always good to start them with metformin. Okay. These are the women, they need to be put on metformin. Right. So it says that, these treatment recommendations may not be according to the standard protocols and recommendations, but it is according to the national resources available. So I would ask the experts' opinion, Dr.
Yes, ma'am. Actually, as per Government of India guidelines also, If patient is less than 20 weeks, then we have to give insulin. It's not the metformin, which is the first line of treatment. After 20 weeks, yes, oral hypoglycemic agents can be used as first line of treatment.
Right. That we
And
have.
it will be done daily
Yeah, I want
insulin.
you. That is what we have decided. We are coming that in the slide. But what is your opinion on putting the patient first on this kind of patient on insulin? Whether you can put them on
No. If patient is poor enough, she cannot come. She should be put on oral hypoglycemic.
Right.
Definitely.
So even it says that, something is better than nothing. Dr.
And-
Kavita, your opinion about this?
From my side, like what you said, that compliance is very important from the patient, especially if she's taking insulin, and self-monitoring. So if these are doubtful, then obviously you'll put them on metformin. And like Dr. Sangeeta said, it is advisable to put on metformin after 20 weeks of gestation. There's one more advantage of metformin, that it brings down the dose of insulin. So patients who require higher doses of insulin, there you can start metformin
That we will
also
come to it.
in combination, so that it brings down the dose of insulin requirement.
Right. Yeah, even there are many other situations, even when you have very high doses of insulin, still the patient is not responding, or the patient is gaining lot of weight, then in that scenario also you can add metformin to reduce the dose of insulin, right? So any specific advice for exercise, what kind of exercise you want to do? I think this question should go to Nidhika Chabra now. Nidhika, we would like to listen to you.
Yes, ma'am. Ma'am, simple isometric exercises also help the patient a lot. I would suggest the patient to do around 30 minutes of walking daily, and the simple PT exercises which we used to do in school, so that the muscle, yes. So simple isometric exercises can be explained to the patient, and she can do it in her home setting itself.
Right, you're right. So 30 to 45 minutes per day, maybe 5 days a week should suffice. So 150 minutes in the whole week should suffice. As you said, it should be a moderate exercise, provided there is no other contraindication for that. Okay, so that is about the exercise. This is what it is just mentioned. This is how we have talked about that medical nutrition therapy for 2 weeks, then repeat 2 hours postprandial glucose levels. If normal, monitor with the same MNT, and monitor like every monthly, maybe during second and third trimester. Of course, baseline, you keep on monitoring the mother as well as the fetus. And anytime it goes above 120, definitely you have to take her on medication. Now we come to, I'm covering only one aspect of each discussion for each case. So we go ahead with the next short case once again, that we have this primey, 20 weeks, parents are diabetic, and she comes to you with the following reports. Blood sugar level is, fasting is 95, and postprandial is 175. So what is your opinion on this, on these reports, on the diagnosis, and on the management?
Yeah, ma'am, I understand that this is the first point of contact of the patient in my OPD. So, and since I would practice I would like to do the diagnostic test and confirm whether she is GDM or not, although her PP is high. But still, I would like to go for the glucose challenge test with 75 grams glucose, and then manage accordingly, madam, depending upon the levels. If it is more than 140, again, I would recommend 2 weeks of MNT, nutritional therapy, along with exercise. And if it is less than 140, then I'll not label her as. But I think it will come more than 140 only, madam, because postprandial is also high.
Right. So would you give her once again? You would put her on the glucose load, or you will follow these guidelines of fasting less than 90 and postprandial less than 120? What would you do?
Madam, I would like to go for a glucose load, madam.
Okay. So now suppose you give her 2 weeks time, MNT, no control. Now what would you like to start her?
Ma'am, since she is 20 weeks, actually what I do in my practice, my drug of choice is insulin, madam.
Yes.
I don't tend to start patients directly on metformin until unless, as you discussed earlier, if the patient cannot come for follow-up or she comes from a remote area, my first choice of treatment would be to start her on insulin therapy.
That is our take-home message. So you are correct. Only when you have these problems, what we discussed, the poor, low socioeconomic status, low educational status, where you do not have monitoring facilities, and the patient may end up into complications because of the treatment, right?
Yes, ma'am.
Then only we have to give a second thought, right? So how much insulin you will like to start and how?
Ma'am, I would like to start her on Atropid or Mixtard. And Mixtard, and depending upon her body weight, madam, in the first trimester we say that it should be around 0.7 units per kg of body weight, the total dose, and in the second trimester 0.8, and in the third trimester it should be 0.9.
Approximately how much? If it is, the glucose levels, you are very well versed, no? 4 units, 6 units, 8 units, that is how you start with the insulin. So if it is, this is definitely more than 160. So you have to start with at least 6 units.
Yes, madam. I would like to give 2/3 of the dose in the morning and 1/3 at night.
Okay.
Yeah.
So, but it is said that if it is only a mild elevation, it is preferable to give single dose at breakfast.
Okay.
Yeah. And then if when you are monitoring the blood sugar levels, the fasting and postprandial. So whether depending upon whether the fasting level goes high or the postprandial level goes high, you have to increase the
Monitor
dose.
the pre-dinner or pre-breakfast. Yeah.
Yes,
Right,
yes,
ma'am.
right. Okay. So about the metformin, we will discuss in detail, but this is just a slide for your reference that even Government of India says that metformin or insulin therapy is the accepted medical management for pregnant women with GGM not controlled on MNT. Insulin is the first drug of choice and metformin can be considered after 20 weeks of gestation for medical management. Right. So all of us agree to this. There is no second opinion. These are the various guidelines, various organizations. They again say that insulin and metformin or oral anti-diabetic agents, they're equally safe and efficacious. That is what all these organizations are saying. There are studies going on, and maybe very soon it will be make sure that metformin can be used even during first trimester, because why we have the practical explanation. Suppose you have a patient of PCOS who is treated for infertility and she conceives, so the metformin is continued till 12 weeks of pregnancy, correct? So all these studies says that there is no higher incidence of congenital malformation when she is on metformin. Okay, so if because of lack of data, we don't make any statement here. Now, when should we start insulin directly? In what conditions? Yes, Dr. Preeti.
Yes, ma'am.
Yes, when should we start insulin? Directly. That is what I want to say.
Ma'am, we have just discussed when the patient is not when the blood glucose is not stabilized with medical nutrition therapy, will be the first drug of choice for our treatment of such patients.
Right. And when you have the blood sugar of more than 190, approximately near 200, then you have to, when she's almost over diabetes, then,
yes, then also we have to go for insulin.
Right. So this is what we have just discussed, that 4-point testing and 7-point testing, self-monitoring of blood glucose levels. Okay. So this already we have discussed. Now, what about maternal and fetal surveillance? We don't have Dr. Pooja here. Dr. Preeti, you can continue. We would like to listen. Yeah.
Yes.
What kind of monitoring you want to go for this patient, and when and how? Fetal surveillance.
Ma'am, we have already discussed the blood sugar monitoring of the GDM patients. And for fetal monitoring, we would like to go for the routine for the ultrasounds like level 2 anti-NB scan, level 2 scan.
Right. Right from clinical, we can talk about. Right from clinical, the fetal movement count, and of course the growth parameters, even clinically, and then even for ultrasound. Right.
Yeah. Yes, ma'am. And whether the patient is going for polyhydramnios during clinical examination, we have to look for that.
Right.
The height is corresponding or it's more than that.
Yes.
The
And
period of
for
gestation.
every trimester, you have to evaluate the mother for complications. Don't forget that. Retinopathy, nephropathy, and vasculopathy. You must evaluate these women. And then, of course, you have to go for HbA1c for the prognosis, what is the control of her previous 3 months. That is how. And this is, of course, third trimester. You have to go for the fetal monitoring, which should be very stringent. So, Dr. Shail, we come to you now with a short discussion again. We have this primary gravida, 33-year-old, 7 years infertility, obese PCOS. She conceived on treatment, continued metformin, and she's diagnosed with GDM at the first visit. She is controlled on MNT. HbA, that is what they feel, that the glucose levels are coming normal, but her HbA1c is 6.9 at 33 weeks, and there is macrosomia on ultrasound. So where things have gone wrong and how do we manage this patient now onwards? 33 weeks already.
Ma'am, since she's 33 weeks, her HbA1c is 6.9 and she has macrosomia and ultrasound. That means that definitely she has had multiple episodes of persistent hyperglycemia.
Right.
And her monitoring was not up to the mark throughout her pregnancy.
Right.
Her continuation of metformin and MNT was not enough to prevent these complications from coming up, which means that we should have started her insulin at some point.
Right. So what I want to say here is point out that in spite of being on metformin, she came as screen positive for GDM. That means the metformin is not protecting her, right? So that is the point where you should start insulin. Yes.
So she definitely should have been started on insulin, and right now we have to work her up for any like nephropathy or retinopathy which might have come up, and she requires to be intensively monitored, at least 4 samples per day, and accordingly we have to intensively control her sugars as much as we can from
So
this
Dr.
point.
Sangeeta, we want your opinion now here. Do we have Dr. Sangeeta? Okay, Kavita. Dr. Kavita.
Here, like things have gone wrong. We know that at 33 weeks she has macrosomia. So that indicates that her blood sugars are not controlled on MNT. So now here I will admit her for at least 48 hours and see that she's following a strict diet control and add on insulin according to her blood sugar levels.
Right.
Also do fetal monitoring, intensive, which has to be there. We can do a modified biophysical profile once per week, and blood sugar monitoring is what required, and set the dose of insulin before she is discharged, teach her self-monitoring and how to maintain a blood sugar diary. All that needs to be done now. And we have to keep counseling her the requirement of maintaining her blood sugar levels, because otherwise she'll end up into further complications like polyhydramnios, and that will lead to preterm labor and other problems during antepartum as well as intrapartum. So every time we have to emphasize that she needs to control her blood sugar, otherwise complications would be there for proper compliance.
Right. So you have answered the second question, Dr. Kavita, where things have gone wrong. Can you throw some light on this patient's management who was already on metformin?
Ma'am, I will add insulin for her.
She has not undergone strict blood glucose glycemic control is not done properly. So she should be started on the insulin.
Right. So on what do you mean? What is your opinion on continue metformin, and in spite of that, HbA1c?
We can add on insulin with the metformin.
Yeah.
Yeah, but that should have been done the soon she was diagnosed at GTM, right? Because on metformin she is screen positive. So the metformin is not taking care of her sugar levels, right? So either you increase, should you increase the dose or should you add insulin?
I would like to add insulin because
I
now
will
she's
also add
having
That is what is
macrosomia.
expected. That is what
Yeah.
is expected. That is what is gone wrong here. that when she's on metformin, and in spite of that, if she's not, if she's again presenting as GDM, that means the metformin is not taking care of her sugar levels. So definitely she has to be put on insulin here, right? Right in the early pregnancy, when she is diagnosed to be pregnant and GDM positive, she should have received insulin. This is one indication where you have to start her on insulin immediately, right? And then stringent monitoring of mother, fetus, everything should have been done. Then, of course, she may not have landed up into macrosomia. Any opinion on the diagnosis of macrosomia, or maybe I would say prediction of macrosomia on ultrasound? I can see Dr. Parneet Kaur raising her hand. Dr. Parneet, do you want to say something?
Yes, Dr. Sneha, good evening. I just wanted to add this in this particular case, we are discussing where things have gone wrong. I just wanted to add that like what we are doing now in inverted pyramid care. So we have identified many risk factors in this patient. She was already 33 years, infertility, obese, PCOS. So proper antenatal care is very, very important. Maybe somewhere we missed the more frequent antenatal checkups were not there, so that is why maybe we have missed her
I
when
would say
insulin
the
have
first
been added
antenatal
in
visit
earlier,
as
because
the
as pregnancy advances, the insulin resistance also increases. So somewhere we must have missed, and insulin should have been added earlier on.
Right. And as you pointed out, the triaging of this patient, the inverted pyramid of antenatal care, that 11 to 13 weeks itself, she should have been screened for everything, right?
Yes.
Other things also, because she's GDM, all these, other risk factors. So even her maternal characteristic, the HDP justice score also goes high, goes
It
to 3.
also goes high,
Yeah,
yes.
so you have to add low dose aspirin, high dose calcium, and all those things. And then she should have been subjected for prediction of the HDP justosis, uterine artery pulsatility index, and all those things. So definitely that is a different aspect, but it's a very good point. And of course, the metformin should not have been there alone. The insulin should have been added. That is what is expected here, so that the baby doesn't become macrosomic. So I was asking about the prediction of macrosomia. Somebody was talking, I think.
Yes, ma'am. We can predict it by doing the best predictor is AC. If it is more than 95 percentile, then definitely the positive predictive value is more than 90%.
Correct.
So abdominal circumference by ultrasound is the best positive predictive variant for prediction of macrosomia, ma'am.
Yes. I agree to this partially, because they say that for growth parameters, AC is the single most, predictive indicator or very sensitive indicator, I would say, for as far as the growth is concerned. But does it really predict macrosomia? That is very early. That is a question. Does it really predict macrosomia very early? Once it develops, anybody can make out that it is going on, it is almost now with all the growth parameters on the higher side. But they say that ultrasound doesn't predict macrosomia very early.
Very early.
Yes. So that is why. So, yes.
Ma'am, some studies have shown that an increased HbA1c level is associated with an increased chances of macrosomia. Even if you control the sugars, the chances of macrosomia developing are higher in patients who have maintained a higher HbA1c throughout the pregnancy.
Yeah. That is because HbA1c is giving you the control over last 3 months, no? So naturally, when HbA1c is high, that means the control is poor. So naturally, with poor control, it will land up into macrosomia. Of course, now how do you go ahead with the management? We take this case ahead. Yes, doctor.
And
yeah, please.
One very important thing is that we have to go for our clinical, a very, very good clinical examination, and a good PA examination also could be a precursor of prediction. I mean, a good PA examination as far as the fundal height is concerned, it is very, very important.
That is
very,
what
very
I
important.
wanted to say, because
Yes.
ultrasound has got limited sensitivity to detect macrosomia, and weight estimation by ultrasound in third trimester, the sensitivity is only 51%. of course, serial abdominal circumference can be 75th centile towards macrosomia. That is what the prediction is. Okay. So what is the role of Doppler in women with diabetes and pregnancy?
Yes, it is very, very important. Now when we are talking of diabetes, we have to be very, very serious in our mind that it since it could be a vasculopathy, so we should keep in mind the other vasculopathies also which can develop. So uterine artery Doppler is a very, very good predictor of developing of preeclampsia in a patient of diabetes, number one. And when we are suspecting that there is development of preeclampsia along with the diabetes, and there are evidence of uteroplacental insufficiency, then uterine artery Doppler for MCA and umbilical artery is a very, very good predictor for early detection of IUGR and the timely management.
Correct, correct. So now we go ahead with the discussion of the another aspect of this now. So we have this, I think Dr. Nidhika and Shail. Dr. Kavita, do you have any comment here on this case? Kavita and Sangeeta, I would like to invite your comments.
Which one, ma'am? Case 5?
No, case 5 we have not started. About
Yeah,
this.
here I want to add that Dopplers are more useful in patients who are overt diabetics with vasculopathy because they are more prone to develop fetal growth restriction. And so for monitoring of fetal growth restriction, Dopplers may be required.
Yes. So this actually, this patient was diagnosed as GDM, that means hyperglycemia at the first visit itself. Okay. So, and HbA1c is 6.9, and she developed macrosomia. So likely that she may be having, pre-diabetes. So these complications we have considered and kept in mind, and we have to follow how we have to predict macrosomia. All these cases we have introspected, and how right from the beginning she should have been taken or shifted to insulin, that we have discussed, and a close monitoring for vasculopathies, growth parameters, right? Now we go ahead with the last case, I think. Second gravida para 1, age 36 years with previous 1 cesarean section. Now she is 26 weeks pregnancy. She's diagnosed diabetic during 3rd month and she's on insulin. Okay, frank diabetes, over diabetes. HbA1c at present is 6.5. Her blood pressure is 150/90. Clinically SGA. How to manage? Dr. Nidhika?
Yeah, madam, she is developing pregnancy-induced hypertension. She's going into preeclampsia now. So we have to be very careful, and her, I would say that her sugar controls are not very strict since HbA1c is on the higher side. Her insulin, her insulin dose needs to be adjusted. Strict control of hyperglycemia levels is very, very important, and I would like to do the routine preeclampsia workup for her. And 28 weeks onwards, strict monitoring and uteroplacental Doppler also is called.
Yes,
is needed, and she should be.
That you will do because now she has already developed. Don't you think that we could have predicted everything and we could have? Yes, 36-year-old lady, previous one teacher, and diagnosed diabetic during 3rd month, right?
Yes,
so, yes. So what you could have done for this patient? What best you could have done?
Uterine artery Doppler in the first trimester can predict. And other markers are also
biophysical and biochemical markers, PLJ, PLT. That could have told you because now. Yes. So you could have started her on low dose aspirin and high dose calcium right from early pregnancy, and then of course the stringent MNT for her. In addition to, because even when she's on insulin, MNT has definitely shown to reduce the insulin requirement. MNT has been very effective in, bringing down the HbA1c levels also. And that is why MNT is very, very effective in avoiding all these complications, correct? So this patient should have been screened right during early pregnancy itself. We should have predicted all these complications. Now that she has developed, anybody will think of managing. So definitely 150/90, whether you would start her on antihypertensives. If yes, which one?
Madam, I would like to start her on levodopa, madam.
Yeah, so you would like to start her on antihypertensive, right?
And I would add low dose aspirin.
Dr. Nidika, we go step by step. You would like to start her on antihypertensives, correct?
After workup, yes, madam.
150/90. No, not after workup. What about 150/90?
Yes.
We want to clarify each and every point. Yes, tell me. Even
she can be monitored, madam.
90. Yes. Yeah, tell me. Tell me.
I mean, she can be monitored in case it persists to be at this level, or in case the diastolic goes beyond 90, then she should definitely be started. If after rest.
So I stop you here. I stop you. I interfere here because previously the NICE guidelines said that if it is 150, 100, then only you should start antihypertensives. But nowadays even NICE has changed its statement, and the World Justices, even FOXY ICOG, and International Society of Hypertension. So all these guidelines say that even if the patient's systolic blood pressure is 140, diastolic is 90 millimeter of mercury, you should start her on antihypertensives. Okay. And International Society says 130/85. You label it as hypertensive and start antihypertensive. Correct? Now what you are talking about is we will evaluate her. Okay, we will evaluate. That means you will investigate her to see whether she's got any end organ damage. Correct?
Yes, madam.
Pressure alone is not the indicator of severity. Nowadays, the concepts are changing. It's previously we used to have mild, moderate, and severe. But nowadays, if you have the alarming symptoms and signs, if you have the laboratory parameters which are worsening, indicative of end organ damage, then even with 140/90, we have to label this patient as severe hypertension. Okay.
I would also like to add her on aspirin at this stage as well, madam, because whatever she might benefit out of that in whatever weeks are left. So I would like to start her on low dose aspirin, and that to 150 milligram.
Okay.
Yes, ma'am.
So age more than 35, previous one seizure, diagnosed GDM during 3rd month, development of preeclampsia, and then growth restriction in the fetus. These are all these complications. So that is what we have discussed till now, that we should have predicted everything at 11 to 13 weeks, or maybe first visit itself, biophysical, biochemical markers, maybe sequential markers, if at all you feel so. Uterine artery Doppler and all those. Then of course you go for target scan because you are suspecting or you want to rule out the congenital malformations, especially the cardiac anomalies, and screening for morbidly adherent placenta because she's a case of previous 1 LSS. So we have to take care of our patient as a whole, right? Our approach has to be holistic approach and not only the diabetes or the hyperglycemia in pregnancy aspect. So monitoring, how do you monitor these patients now? The 7-point testing and everything we have discussed. For this patient particularly, what will be your plan of management? This patient particularly. 26 weeks pregnancy, mild, she has developed hypertension, she is diabetic, and she's got SGA.
Ma'am, strict fetal surveillance, and she should be taught daily fetal movement count after 28 weeks, 38 weeks, 30 weeks, so as to catch any earliest sign of fetal distress. So that has to be taught, and after 32 weeks, NST every week. I would call her for NST every week.
Okay. What about sugar levels? How do she's on insulin? When do you test her blood sugar levels?
I would suggest, ma'am, she should do it every alternate day.
Okay. So we have said that every 3rd day, but if at all there are fluctuations, almost every day. If at all there are fluctuations, maybe we have to monitor them daily. Right?
Okay. Right. Okay.
So now maternal and fetal monitoring, because now she is developing hypertension. So weekly you have to assess her, even for the liver and renal function test and all those, parameters, what you want to, you have to make sure that she is not landing up into end organ damage, because till then you can pull this pregnancy ahead. And then how do you prepare this fetus? Because this is definitely going to be an early delivery, right? So how do you prepare this fetus?
I would like to give her a dose of antenatal steroids with the cover up of increased dose of insulin for 48 to 72 hours, madam.
Why is that so?
Because steroids will definitely worsen her hyperglycemic status,
Correct,
madam.
correct. We have to clarify it for the attendees. So
Yes.
yeah. So we must hospitalize her. Maybe we have to monitor her blood sugar levels, because for around 48 hours, it definitely leads to disturbance in the sugar levels. And then you have to increase the insulin. Any comment on the magnesium sulfate?
Madam, I don't administer, so so far for neuroprotection, I haven't,
Okay. Anybody, Dr.
Yes, we are giving for the neuroprotection less than 32 weeks. It is given.
Yes, in fact, it is recommended that 32 weeks plus 6 days up to this gestation. There is a very, very high, recommendation for magnesium sulfate as neuroprotector, because we have been routinely using, if at all we have such patients waiting, whom we are preparing, that yes, we keep the baby so well prepared that later on, you don't have to worry so much about this. So how do you, I think, Dr. Preeti, do we have Dr. Preeti? Just the last comment on the steroids, what steroids, and magnesium sulfate, how much and how?
Yes, ma'am.
Dr. Preeti?
Yes, ma'am.
Yes. So which steroids and how much you give?
Ma'am, dexamethasone 8 milligram, IM stat, and second dose after 12 hours.
No. Total dose, how much?
8 milligram, ma'am.
Six. So total, it's basically
24 milligram. 24 milligram.
It is 24. So Foxy and IAP both have come up with a joint statement. There's a lot of confusion on this betamethasone, dexamethasone. So in Western countries, betamethasone acetate, the salt is available. What salt we are using is propionate, and it's not the same one what is effective there for lung maturity. So Government of India has come up with dexamethasone. So whether you use betamethasone or dexamethasone, but at least 24 milligram over 24 hours, that is the accepted strategy, right? So 24 milligram over 24 hours. So 12 milligram 24 hours apart, or maybe 6 milligram 6 hourly, different regimes, okay? But 24 milligram over 24 hours. That is what is the dose for the steroids. And then magnesium sulfate. Yeah, Dr. Shail.
Yes, ma'am.
So how do you administer magnesium sulfate for neuroprotection? We have been
4 grams is the loading
and 1
dose.
gram per hour.
Yeah. And 4 grams has to be given over 20 minutes, and then you continue with 1 gram per hour for 24 hours or till the baby is delivered. After 24 hours, you have to stop it.
Yes, so 24 hours is the limit, right? So nowadays, previously it was quite difficult to calculate the dosage, because for eclampsia, we had that 50%, 2 ml. So one ampule is 1 gram. So 4 gram is 4 ampules. That was for initial loading dose. But 1 gram per hour. So you have to, in 500 ml, we have to put 5 ampoules. So that is what it was calculated. But because of this, there was lots of fluid, in these patients, especially who are preeclampsia or hypertensive patients, in whom there is a fear of fluid overload. Nowadays, we have that 100 ml. Some noise somewhere. So here nowadays, we have max for 100.
Dr. Preeti, please mute.
100 ml, we have the 100 ml fluid, IV fluid, which has got, 4 gram. Okay, so 25 ml per hour. That is what we administered nowadays. That is 1 gram per hour. And it is available. So initially you give 4 gram. That is the first 100 ml. You give it immediately over 20 minutes. And then over 24 hours, that means 1 100 ml pint, that is for 4 hours. So you give 6 more. So for any patient, you require 7 pints of 100 ml IV mag. That is what is the calculation. Okay. So you don't have to calculate and break the ampoules and add it. You have a ready to use solution of IV magnesium sulfate nowadays. Now, how do you monitor the control of the diabetes when suppose this patient has got now FGR? I would just ask the last question. This patient has FGR, so we would try to deliver her as soon as if there are some problems with the baby, the Dopplers are getting altered. Maybe there is absent or reversal of end-diastolic flow. That is a condition where you may have to deliver this baby, and by the time you prepare it. But suppose the patient has got very well controlled sugar levels and even the baby is growing well, then how long you want to hold this pregnancy? Dr. Satinder. I think I will stop this, stop sharing, and I would just listen to you.
Yeah. Now the latest studies say, because we have very good modalities available for monitoring. So if it is a well-controlled GDM, we can some of the without any evidence of any end organ disease, and there is no fetal and the maternal evidence of any distress, then we can definitely take this pregnancy to 39 plus weeks also if the patient is well controlled on GDM. But if she is GDM in controlled and on very, very high dose of insulin, and we may suspect at any time that she has developing any evidence of uterine placental insufficiency, then we have to deliver the patient according to that. Otherwise, a well controlled 100% we can take. Some book says we can still take, don't cross 40 weeks, but we can still take till 40 weeks if it is well managed, well controlled GDM.
Yes, I would add to this. I fully agree to this. Only thing, if she has no previous history of stillbirth.
Yes.
If she has no previous bad obstetric history, and if she has no other complications.
Yes.
Whether obstetric or because of diabetes.
Yes.
So if at all things are fine, then we can pull her on up to 39 weeks. Still, I would say only 39 weeks, because otherwise also in a non-diabetic pregnancy also, unexplained stillbirths, that is called as inevitable stillbirth rate, is quite high. And that is why in this patient, we will not take any risk for, going beyond 39 weeks. And that is why we would love to induce her at least.
Yes.
Correct?
Yes,
so now, suppose you have a patient who's got macrosomia, definitely more than 4 kg, you will take her up for cesarean section, elective Caesar. Now, in between patients, we have said that we will take her up to 39 weeks. But suppose you have this complicated patient whom you are just trying to pull on. So what will be your optimum gestational age where you want to pull on?
Now,
37 weeks.
37 weeks plus. 37 completed weeks.
Right. So definitely when things are fine, everything is going fine, at least 37 weeks. But if at all you have very severely disturbed control, and if at all you have this growth restriction and the baby fetal parameters, the Doppler parameters worsening, then I think 34 weeks we have to set the target and prepare the features and deliver the. Now, suppose you have induced, then what do you do with the dosage of insulin? How do you go ahead with the dosage of insulin?
Very, very important. If the patient was already insulin, then I'll give the night dose of the insulin. I'll omit the morning dose of the insulin. Then it is very, very important. I have to take into account two things. One is I have to take into account, I have to do in a patient in which I have induced, I can do even 1 hourly sugar level in the beginning.
In fact, I would say we have to monitor the patient sugar 1 hourly, every hourly. And how much it should be around?
Yeah, the RBS levels could be between 120 and 140. And the second
105. We don't want any time it should go above 120. So around 105.
So on one side, I'll start the normal saline, and with according to the sliding scale in that normal saline, I'll add the insulin, and on the other side, depending upon the sugar levels, I'll have to take care of the nutrition of the patient also. So on the other side, I'll have to start the nutrition drip, and I'll maintain a proper partograph. I'll keep very keen watch for any evidence of prolonged labor, and I will have to mentally prepare myself also and my team also that at any time I may have to take the patient for any operative vaginal delivery or cesarean section because of incoordinate uterine action, and I have to be mentally prepared for all types of PPH also during
Right. So
cesarean.
if the sugar levels are around 100 or 105, you need not start any infusion.
Yes.
I mean to say any insulin, but you have to keep the patient well hydrated and continuously monitor her. But anytime the sugar levels goes above 120 to 140, you have to start with the normal
Insulin.
saline insulin infusion, and this
Infusion.
is levels of insulin. It is recommended
According to
levels.
sliding scale. Yes, ma'am. Yes, exactly.
So this is what is the postnatal follow-up, and of course, what you have to warn her that you have delivered doesn't mean that things are over. If you don't follow these same medical nutrition therapy, active physical exercise, then down the line, almost 30% of these women develop frank or over diabetes in 5 to 10 years, and almost 50% in coming 25 years. And of course, the contraception, this is MSC criteria 2. This is the intrauterine contraceptive device. That is what is recommended. So basically, to sum up, insulin is the preferred treatment of choice for even GDM or hyperglycemia in pregnancy. Metformin should not be used as first line agent as it crosses the placenta to the fetus before 20 weeks, definitely. And metformin, when used to treat PCOS and induce ovulation, should be discontinued by the end of first trimester when the patient doesn't have hyperglycemia or when the patient doesn't have GDM. This is what we have already discussed, how you should go for the insulin titration, right? So with this, I conclude the panel. I thank the organizers especially, and I thank my experts, Dr. Sangeeta and Dr. Kavita. I would like to have your expert comments, if at all you have. But before that, I just take this humble opportunity to request all of you to support my candidature as Foxy Vice President from West Zone for the upcoming elections. The elections are very close from 1st to 10th August. And for West Zone, you have 2 votes. Okay, you have to vote for 2 people, 2 candidates. So please make me as your first choice so that I can continue serving you people, and I can represent all of you well.
100%, ma'am. 100%.
Thank you so much. Thank you. I
Thank you so much, ma'am. Thank you so much.
All the best.
Thank you so much. And thank you so much for giving us a chance to hear such pearls of wisdom from you. These types of webinars are so important that they've made us prepare one very important lecture.
Thank you. Thank you, my dear. And in fact, it's, learning together. All of us, we progress together. So that is what is the idea behind such virtual programs. And I can see Dr. Iqbal sir also, listening to us till the end. So thank you so much, Iqbal sir. And we would like to have your blessings. Please unmute. Please unmute, sir. I think sir wants to say something. Saiti, if you can help him. Please unmute, sir.
Oh, it was a very nice. It was a very nice and informative. I think I become wiser. And I wish you all the best. And I think I declare as a winner.
Thank you, sir.
All the best.
For your blessing.
All the best.
Thank you, sir. Thank you so much.
Ma'am, can I say something?
Yes,
Ma'am, I have participated in many of your panel discussions. It's always very, very informative and very interactive also, because we get involved in the panel so much. And I have seen you moderating it all so well every time I've been there. And I think all Punjab societies will be there for you in your future
Yes, ma'am.
endeavors.
Always do.
It will
Thank
be
you
fun
so much.
pleasure to have all of you with me. I am a person. Let me once again declare that this is a disclaimer. I don't believe in any regionalism, casteism, and I'm a very broad-minded personality, and that's a very reason. Even I have taken my Amogs platform also to all the states of India, and people are so close to me, and the only aim is focus, knowledge sharing. So thank you so much for, getting associated with us and giving me the opportunity to, in fact, to interact with all of you. Thank you so much. And thank you so much.
Thank
for
you
your
so much, ma'am.
Thank you so
Lakbir
much.
ma'am, do you want to please add something, ma'am? I can still see Dhaliwal ma'am.
Madam.
I have learnt a lot today. Good revision of the three topics. Good revision. It was nice. I actually went to the labor room mentally, how to manage this hyperglycemia in labor room. So it was very nice. Good revision of three topics.
Yeah.
Thank you, madam. Thank you so much. Vidhu.
Thank you. Thank you, ma'am. Thank you, everybody, for joining us. And, as Dr. Kavita said, that जो भी Dr. Sneha के साथ हम करते हैं, so, she takes it very meticulously and everything is so detailed. So we are absolutely, by the end of it, we know what we have to do and what we don't have to do. So we are absolutely crystal clear of all the topics. And thank you for all of us, for all joining and learning together. It's learning and sharing together.
Looking forward to work with you and represent all of you. Thank you so much. Please.
All the best. I think so.
Thank you, Sneha ma'am.
As I said, you're already a winner. So
I know. Thank you so
Thank
much
you,
sir, for your blessings.
Thank you, Sneha ma'am, for the opportunity to coordinate this webinar. Thank you, Vidhu ma'am and Sangeeta ma'am and Kavita ma'am for being the conveners and coordinators for the entire program. Sahiti, thank you so much for the technical help and the seamless conduction of this webinar. I also like to thank all our
Thank you, Monica.